Well, hello, everyone. I'm Victor Zhao. I'm the president of the National Academy of Medicine. And good morning to everyone on the West Coast. I'm very disappointed I can't be with you in person. Earlier, I heard that you've got a sunny weather. Well, you know what? I just have to do it vicariously. But I'm delighted to join you virtually to kick off this important meeting. First, the collaborative. Since 2017, National Academy of Medicine's Clinician Wellbeing Collaborative has convened, published, and shaped national conversation on clinician burnout, stress, and related issues. Our goals over the years have been to improve the understanding of the challenges and to advance evidence-based solutions to improve patient care by caring for the caregiver. So health technologies from electronic health record to ambient listening are shaping the daily work of clinicians for better or for worse. In the NAM's consensus report and the national plan that you may and may not be aware of, certainly our members are, the collaborative stress the importance of engaging clinicians in the design and deployment of health IT and digital technology to show effectiveness, efficiency, usability, and safety of technology. So back in 2022, our collaborative convened to discuss the impact of health IT on clinicians. And we heard from health systems that have successfully deployed tools to reduce provider burden. But we also examined national barriers to catalyzing wider implementation of such innovation. Many of those barriers persist to date, including interoperability, adequate federal funding support deployment. So today, given the fast-paced evolution of AI, there's even more pressure on health systems and policymakers to address these barriers. Our goal today is to get closer to addressing these barriers by unpacking the impacts that AI will have on clinicians now and in the near future. Now, we all know that AI is undoubtedly one of the hottest topics of healthcare today, sparking great excitement, optimism, but also uncertainty about its potential to revolutionize the way we deliver and experience care. In particular, AI holds incredible promise to reduce burden on clinicians. Well, however, it's important to acknowledge that AI is not a monolith. So we really need to examine the utility of specific tools while recognizing that new technology, no matter how innovative, will come with trade-offs. Take, for example, AI scribes, tools to transcribe patient encounters and leverage machine learning and natural language processing to summarize clinical conversation and produce documentation. Well, these two, while they aim to reduce burden, we must ask if they are. One, are they achieving the promise? And two, for which clinician are they effective? So you all know that some data show doctors think that notes produced by AI scribes still require a lot of editing and rewriting, and they haven't saved them any time. But on the other hand, one study of same AI tool, ambient, for example, implemented with nurses showed great significant time savings per inbox message, resulting in overall time savings. So what do we believe in? Well, we must ensure that AI is optimally designed to meet the needs of all types of clinicians. So that's part of our conversation today, right? Would it save time? How is it designed? And can it be done in such a way that really help us to meet the needs? And in addition to time saving, tools must be able to reduce cognitive burden, which is a key component of clinician well-being. This underscores the critical need to, one, having clarity of what data indicate, and two, carefully balance the benefits and drawbacks of current AI tools, especially in the clinical practice. If implemented without careful consideration, AI technology can risk exacerbating challenges like clinician burnout. On the other hand, if thoughtfully integrated with the intended user in mind, AI could become a powerful ally, streamlining tasks, enhancing decision-making, and most importantly, creating space for clinicians to focus on what truly matters, building relationship with patients and improving care quality. So I want to briefly touch on 4 key considerations related to AI as an impact on healthcare workforce. First, we must assess the efficacy and time-saving potential AI applications, which tools truly save time and improve efficiency. And understanding the current landscape and anticipating how these tools may evolve is really essential. Second, we must ensure that implementation of this technology empowers healthcare workers. If AI can indeed save time, how should the tool be plugged into the workflow of clinicians to reap the benefits for the entire care team? How will workflow need to change? And moreover, will this newfound efficiency allow doctors and nurses to spend more time with patients, strengthen relationship, and providing better care? Or will health system instead use AI as an excuse to further burden already strained workforce by saying, hey, you got more time, see more patients? So this is really important in this discussion that we're looking at AI forward. And the third point I want to make is that we must consider which scenarios AI can act as an appropriate proxy for work of professionals. Can AI truly replicate or replace the work of humans in meaningful ways? Or are there use cases that risk undermining patient care by neglecting the invaluable patient perspective, human perspective, that only healthcare workers can provide? The last thing we want is to exacerbate feelings of patient, healthcare workers' alienation. And finally, what about the cost and payment? You know, I hear that only some select hospitals, maybe those are financially well-resourced, are willing to bear the cost and burden of these technologies for the clinicians. So there's widening digital equity gap between institutions and clinicians who are capable of financially supporting AI and those who have not. And imagine if this cost is transferred to clinicians. They have to bear the cost, while in fact what they're trying to do is improve patient care. So we need to really understand all those issues. And finally, we need to demystify the cost of investing AI so it is less risky for hospitals to integrate AI and to avoid additional costs for already overburdened workforce. Wow, lots of issues on there. That's why we're having this meeting. Because, you know, if you really want to take a step back and think about with such hype in AI, we need to have a clear strategic action to ensure the thoughtful implementation of AI in healthcare. You know, some of us are becoming more skeptical than others. But by the end of the day, I want people to leave with a deeper and better understanding of the issues at this meeting. The real question is, will everybody be able to agree on the holy grail use of AI in healthcare? Or is much more research and learning is needed? This meeting is the beginning of many discussions to come. We recognize and collaborate how important this issue is. That's why I give credit for the steering committee, for our co-chair, for An, to jump on this issue to say, let's start addressing this now. Now, so I want to thank University of California, San Diego. They have recognized the need on this issue, and they partner with us, the NAM, to examine these priorities. So I want to thank the Joan and Irwin Jacob Center for Health Innovation and the UCSD Health Office of Physician Wellness for making this event possible. I want to include Patty Mason, the CEO, Sonia Ramamurthy, the Interim Director of Physician Wellness, Chris Kane, and his Wellness Oversight Committee. We have 4 exciting sessions lined up today, which will provide insight how AI applications can support health workers' well-being, highlighting potential use cases, address key stakeholder considerations, and identify ways to avoid common pitfalls in the digital transformation. I'm also excited to hear from my good friend Tom Ferris, whom I've known from Mass General Brigham days, who was the former National Director of Transformation at NHS England. And of course, he's bringing lots of experience with him. And we thank him, Tim. Thank you, Tim, for your contribution and for speaking to us. The planning committee for today's workshop is Christopher Longhurst and Jackie Gerhardt. You heard Jackie earlier on, and they consist of STEAM experts who generously volunteer the time, expertise to design this meeting. And the work, of course, has been supported by my dedicated staff and staff across the academies, including Antron, Rita Ahmed, Bram Bond, Ash Ranka, and Samantha Phillips. Their commitment and efforts deserve the greatest gratitude. Can you help me give them a round of applause? Okay, without further delay, let me turn over to Chris, who will add their final opening comments to kick off today's meeting. Thank you.
Thank you very much, Dr. Zhao. I want to provide a warm in-person welcome. Unfortunately, not as warm as we would hope. I apologize for the weather. It's supposed to hit 65 today, but it does feel like 70 if you're standing in the sun. For those of you staying through tomorrow, it will be a little bit warmer. The good news, though, is that the wintertime is the best time for sunsets. And so I have to tell you, I'm equally excited today about these 4 sessions, learning from all of you, and what I expect to be an absolutely extraordinary sunset. And our 4:30 adjournment has been scheduled around that sunset. So please make sure you join us. You see here our learning objectives for the day, and I'm particularly excited about this because, as Dr. Zhao suggested, there's a lot of evidence coming to light, and I think the most single clear point is that AI is not a silver bullet, right? There is a lot of potential in AI to help us, but we're learning more and more that what seemed like absolutely unbelievable kind of data about improvement in time and experience as the peer-reviewed literature is coming out is backing up a little bit. In fact, just last week, our colleagues from Atrium and Adventist Health published a large study showing that the AI scribes had had a significant improvement on physician experience, but not a significant improvement on time spent. Our colleagues from Stanford published another smaller study suggesting that there was an improvement in perception of time, though not actual time improvement, which one could argue may be equally important. So presenting that available research on the impacts of AI and health care worker well-being is critically important. Exploring use cases where applications of AI have demonstrated clear or promising benefits for healthcare worker well-being, and then discussing how stakeholders can navigate and prevent digital transformation pitfalls in the current and future healthcare environment are our objectives for today's meeting. And again, really appreciate everybody joining, both those online and those who can join us here in San Diego. I'd also like to thank the planning committee, and so we've got a roster here we'll put up on the screen, but I do want to in particular thank Dr. Bill Mobley, who's the director of the Sanford Institute for Empathy and Compassion here at UC San Diego, as well as Habib, Habib, raise your hand, is in the corner, has put together a lot of these logistics along with the rest of the planning committee. So thank you to my colleagues on this planning committee. Thank you particularly to Dr. Jackie Gerhardt for being my co-chair on this effort. And we're incredibly excited for today. And so before I turn this over to Dr. Ferris, I'll just remind those of us joining us
Chris?
Yep, Dr. Zhao.
Can you ask Ann to send me a link? I'm only seeing you and Ann. I'm not getting the overarching link. If you can send me a link to the meeting.
I think that they're hearing you, so links should be coming. And
okay.
For those of you joining us online, you can submit questions throughout the day using the Slido underneath the live stream, which Dr. Zhao, I expect you'll be able to see soon. So again, thank you to members of the Planning Committee, and Dr. Ferris, we're looking forward to your opening talk. Thank you.
Good morning, everyone. Well, it's a real pleasure to be here to see some old friends and some new faces. I'm excited to participate in this event. I can't think of a more important topic, especially as a father whose daughter was just accepted at medical school, and so is looking forward to going to medical school. And I'll tell you, a lot of people have asked me, tell me, well, so you were unsuccessful at dissuading her from going into medicine? And I said, I don't share your views about the future, and I hope to, by the end of this, that I will get there. I need to do some housekeeping first. So I was told to do a very thorough conflicts review. So I have a staff appointment at Mass General. I'm an adjunct professor at Harvard. Those might not be conflicts, but I currently advise 2 venture capital firms, Morningside, which is Gerald Chan, as in the Chan School of Public Health, and F Prime, which is Fidelity's venture capital firm. I specifically advise them in the area of health information technology and AI. I also sit on the advisory board of Codemetrics. Codemetrics is a company that I founded when I was the CEO of the Mass General Physicians Organizations, because I couldn't believe that we employed 360 people to do our billing, and now the MGPO employs about half that using technology that is now part of a company. I sit on the advisory board, and I do have some equity in that company, full disclosure. And then finally, I advise the UK Minister of Health on health policy issues, mostly related to technology, both in healthcare and in social care. And I have oversight over the Working Committee on AI in healthcare. So, prior to the pandemic, my team at Mass General published several studies on physician burnout. We wanted to take a broken windows approach. And so we asked physicians very specifically, what are the things that are burdening you that you're most complaining about? 8 out of the top 10 were technology related. That was a surprise to us, but not a big surprise. It makes a lot of sense. But we learned something. So first of all, documentation was the number one, by far the number one. And so we put in place, actually, it's sort of funny to think about it now, but we put in place ambient documentation. This was 5 years before LLMs were invented. But we did it, you may have heard about this, there was a couple companies in India where during the night, while you were asleep, they would listen to the transcription or read the dragon text of your encounter and then turn that into a physician's note. I will say that there weren't, when I was walking through the halls of Mass General, there weren't very many things that I did where I was thanked openly by the doctors. That was definitely one of them. Now, about 20% of doctors didn't find much benefit from it. I'll tell you, it was very specialty specific. The hand surgeons at Mass General had macros for every patient they saw, and they just pressed one button and their note was complete. I think they had to adjust whether it was the right hand or the left hand, right? But whereas the psychiatrists and the primary care doctors, where the burden is much higher, we're incredibly thankful. But as these things always go, the important lesson for me for this group was actually what happened after. Because once the physicians had this, it didn't take very long before they forgot what life was like before they had it, right? And there was a lot of discontent among the physicians, as there is now. And it became clear to me, sort of obvious, that the broken windows approach was important, but there were larger issues at play here than just technology, obviously. My opinion is that the larger issues, if I had to pick 3 words, they would be 3 phrases, they would be increasing complexity of care, the associated clinical risk, and physician agency. Those would be sort of my top ones. Different people have different top ones. The increasing complexity of care is actually a product of our own making. It is, in fact, a product of an incredible success. And that success is the advancement of science in the creation of diagnostics and therapeutics. When I started practicing medicine 35 years ago, there were many conditions where patients were admitted to the hospital. I would see someone and I didn't have, and I could care for them, I could give them consolation, I could explain their issue, but I didn't have something to do, I didn't have something to order, because there was no therapy for whatever it was. That is just incredibly rare now. And that complexity is new to us. It's a boiling the frog. We don't perceive this happening over time. But for example, just last year, the FDA approved over 400 new indications for therapies. When I started practicing medicine, they were approving about 40 a year. Now it's over 400 a year. That complexity is one of the two main ingredients that is contributing to the massive cognitive load and burden on people delivering healthcare. The second one is, of course, something that I'm personally involved in. I was born in the very last demographic month of the baby boom. So I know I don't look like it, but I'm a boomer. And the baby boom is creating an extraordinary issue for the delivery of healthcare, because all of those older people like me have multiple chronic conditions, 4 on average at the age of 60, 8 on average at the age of 80. So you take the fact that we have all these therapies now. There were a lot of things we just couldn't treat before. And the burden of illness, and it is that demographic wave combined with innovation that is creating, to my way of thinking, the extraordinary cognitive load problem on our physicians. And not just our physicians, I will say this is across all nurses, allied health professionals. So, so sorting through the complexity of all this, so my patients with multimorbidity and all of the medications they're on, sorting the interactions of those medications, like what could one be doing to the other, and I'll use these words quite purposefully, it is not humanly possible. It is not humanly possible to sort through that complexity. No human brain has the capacity to sort through that complexity for an individual patient, I will submit. And so last week, I met a young cardiologist practicing in Florida, and he told me a now familiar story. He quit working for his private practice cardiology group in Florida, which, by the way, I don't know, back in my day, they were basically among the best paid doctors on the planet. And he quit his job for that private practice cardiology group and now works as a cardiologist at the VA. And he is loving life. He has a young family, 3 young kids. His wife works. He has no administrative overhead. He isn't being chased by anyone in the practice about billing and seeing more patients. He sees as many patients as he feels comfortable with. He made a work-life balance choice to forego 50% of his income, and he now currently sees about 25% of the patient volume that he was seeing before. And he thinks that, what a great trade-off. That is totally understandable, but it makes me worried. It makes me worried because physicians all over the country are making the decision to cut their time and see fewer patients so they can go back to caring for people. At the exact same time that we have this demographic wave with all this innovation that has created an extraordinary demand for healthcare, extraordinary demand. So what are we going to do about that? And I want to emphasize the point here because the US is showing signs, to me, of a looming capacity crisis. So I just spent 3 years in the NHS, and a plug, I wrote a paper that published in the New England Journal 3 weeks ago about the lessons from the NHS. But all of the things that were happening a decade ago in the NHS are happening today in the United States. So waiting times to see a specialist are up dramatically in the United States over the past, it's a boiling the frog thing. It's getting a little worse every year. It's never a crisis, but it's getting worse every year. Many people don't know this, but despite our high costs in the US, we have the third lowest number of acute beds per 1,000 of any OECD country. Like, how is that possible? We have a shortage of acute beds. So what was happening in the NHS 10 years ago is they started having borders in there. They called them the A&E. We call them the ED. Well, guess what's happening in the United States? In every urban medical center in the United States. At Mass General, when I came down as an intern, there were 7 or 8 patients waiting in the emergency department to be admitted. On average, every single day for the past 2 years at Mass General, there's been over 100 patients waiting for a bed. Think about that. That's 10% of the bed base of that hospital. Okay? That is happening in urban medical centers throughout the United States. Okay? So we've got an interesting situation developing here. Again, very slowly, but it's inexorable. And we're not even close. The baby boom sort of caps out in 2045. Right? That's when it starts to level off. So we have increasing pressure, demographic pressure, until about 2045. Different demographers will answer that question differently. I don't sweat the difference. So will technology solve the problem? That's another way of saying what Victor was asking at the beginning. And so will we move from a one-to-one, basically a one-to-one service delivery model, to a one-to-many service delivery model? Will people use autonomous services to get advice and navigate the health system? Will physician work be more focused on the exceptions and also on personally caring for people and less on administrative work? So in my job as head of technology at the NHS, and now in my work advising venture capital firms, I regularly meet with senior leaders in major tech firms as well as tech entrepreneurs, and I get to test their wares. I get the preview of a lot of the stuff they're working on. I feel very lucky to do that. And yes, there is a lot of hype, but yes, it is extraordinarily impressive. I have tried multiple times to break LLM diagnostic machines, and I couldn't. Like, they are really, really good. And do I spend time worrying about hallucinations? You know, there's been a lot published about hallucinations in generative AI models. Let me just say, I have sat on the wards in hospitals listening to other physicians on the phone with patients and other doctors. I've heard a lot of hallucinations. And in fact, one of the issues here is, one of the great things about AI is you make a mistake, you train it, it never makes that mistake again, ever. Like, it can't make that mistake again. Is that true of people? And another thing, again, I'm not overhyping here, but everything an AI model does, it records. Can we say that about what we do in healthcare? Like, did we actually know what happened? Well, I'll tell you what my nurse said to me when I had an ambient documentation. I said, so what do you think of my notes now? And she said, you mean, what do I think about the fact that I now actually know what you said to the patient? I was like, okay, thanks for the honesty, right? So, so I want to be clear in terms of the health information technology that a lot has improved in this process of, you know, electronic patient records. A lot has improved. So most patients in the United States today can see pretty much all of their records at their fingertips 24/7. That didn't exist when I started practicing medicine, and it has changed everything for the better. Also, closed loop prescribing is a much, much, much safer activity than it used to be, all because of the electronic patient record and the associated health information technology. So I don't want to say that there hasn't been major steps forward, but it has come at a big cost, and the cost has been mostly on the clinicians who have to use those systems. It is about what is called in the tech world the UX. I think the next decade will be a decade where health information technology becomes the big story, and that actually the practice of medicine in any profession will look dramatically different than the way it does today. And the reason I say that is I don't have a lot of confidence actually that physicians are going to, and other health professionals are going to be rapid adopters of this stuff. Actually, I have very little confidence. But you know who's going to be rapid adopters of this stuff? Patients. Because I can tell you, as those access problems mount, and you have an option to take a picture of that skin lesion and get it diagnosed with 99% specificity and sensitivity, which is what 3 different companies can provide, FDA approved drugs. Well, why aren't those systems currently widely used in the United States? Rhetorical question. Okay, obviously, because it undermines the business practices of dermatologists. Full stop. Okay? And that's why. But patients won't accept the fact that there is a solution, a low-cost, high-quality solution that exists out there that they don't have access to. They will get access to it. I am quite confident of that. And I just hope, and this is what I wanted to close on, is, well, actually, I had a couple more things to say. Do I have time? How am I doing on time? A couple more things? 5 minutes, okay. I'll come to the hope at the end. So how is this going to happen? So I see 4 categories of AI-based health information technology. I wrote this in a paper which we will send out the link to, called Unit Cost and Hope. And those 4 categories are basically, the first one is clinical verticals. There are now thousands of cool things in a clinical vertical. So there are headphones made by a company that, I don't know where and I don't know what the name of it was, but I've used them. And basically you put on these headphones and whatever your ear problem is, it will diagnose it. Okay? That takes a couple seconds. You can do it anywhere, okay? There are stethoscopes that are effectively echocardiograms, right? You actually can get valve information from a stethoscope. Like there are literally hundreds of these that sit within a clinical vertical. And by the way, they all use AI, but it's not the kind of AI that people worry about. This is all AI with narrow outcomes, so it is trained on a data set. It can't hallucinate, just to be clear. The hallucinations are something that come with the type of AI, which are the LLMs. So those are the clinical verticals, and they will change things. By the way, there is a company, again, FDA approved, that you can take as a parent 2 3-minute videos of your 2-year-old, and it will tell you whether or not your child has autism. Do you know how long it takes to get in to see a pediatric neurologist in the United States today? 18 months. Those 18 months are critical, is a critical time for the brains of infants. Okay, why isn't that immediately adopted everywhere? I hope we spend some time talking about that during this symposium. So the second is what I call cross-cutting software. So it goes across everywhere, and that ambient documentation is just one of those. But I'll say the real big one here is clinical decision support, whether that's for the patient, answering your questions. And a lot of the ambient documentation companies are moving into this space because the bar for doing ambient documentation now is quite low. I have a friend who just opened up ChatGPT, had it transcribe a visit with a patient, and the ChatGPT note was pretty much the same as 3 other of the major software vendors. And he was like, oh, so why am I buying this software, right? The third is operational analytics. AI is going to produce an enormous amount of benefit in operational analytics. Things that, because of how complicated our healthcare delivery system is, that we don't even know are bottlenecks and problems, AI can figure out quite easily. Of all of these, the most transformative thing by far is clinical decision support. So I've already said, honestly, I'm not worried about the hallucinations problem, enough said on that. I am worried, though, about one big trend. I talked about this very briefly. I had a sentence on this in the paper, in the New England Journal. I am worried about the effect of venture capital, private equity, the tech giants, and the insurance giants. They are all in this space. They are heavily investing in AI because they see that a major undermining of the established delivery of healthcare. They see much lower cost, higher quality care, and those organizations are being incredibly aggressive about the acquisition of technology that can seriously undermine the delivery of healthcare. But the problem is, and I will just say, they're doing great stuff, the technology itself, but where they're headed is they want as big a chunk as possible of the $3.5 trillion that is the healthcare market. And boy, pay attention to what they're doing, because they know what they're doing, and they know that if they offer something of high quality to patients, patients will vote with their feet. And they will not be going to the doctors employed in the standard old-fashioned way. They will go to doctors who are overseeing LLMs and technology that gives them the answer that they want right now and is a high-quality answer. So I am worried about that. And then I'm worried about, as a profession, any of the professions, showing leadership. I'm ending. I'm there. I can tell you're. But I think it is on the professions to show leadership in this moment, because of the things are going to start shifting quite quickly, I think, in the next several years. And that leadership means 2 things to me. It means being aggressive about adopting things that are clearly good for patients. I'll just say, I don't see that happening now in the medical world. I do not see aggressive adoption of clearly beneficial technology. I see guild protectionism, honestly. That's what I see. And the other thing is, having said that, we need to be assertive about adopting it. We also, if we are assertive about adopting it, we will also be in a better position to make sure that we're taking the fruit, and to quote my favorite author, Chaucer, taketh the fruit and let the chaff be still. Like, make sure that we're getting the good parts of it. And this time when we do health technology, let's make sure that the UX really works for the people delivering healthcare, as opposed to the last time during the High-Tech Act where that did not happen. So I am optimistic about the future. Technology will help us successfully address our growing capacity challenges. And we may actually finally have something that was first written about in the mid-1970s. This idea is sort of the city on the hill of the learning health system, where a health system actually, as it does its work, learns how to do its work better. That has always been out of reach because of the practical hurdles of the management of that process. Actually, a learning health system is now within reach because of AI, and that is, to me, an incredibly exciting prospect for both my daughter going into medicine, but also I hope my grandchildren and their children in the receipt of higher quality, lower cost, very efficient healthcare. So thank you very much. And do I sit down now? Yes, I do.
I'll have the panelists come and join me here, please. So I'm Lottie Derby. I'm Chief Wellbeing Officer and Senior Associate Dean for faculty at University of Colorado School of Medicine. It's my pleasure to serve as the moderator for this session here. I'm just going to do a very brief introduction of the panelists. There are various QR codes in the building here where you can scan and see the complete bios of everybody who's going to be part of this session. So I'm joined by Christopher Longhurst, who we already heard from this morning, Chief Medical Officer, Chief Digital Officer at UC San Diego. Margaret Losovetsky, who's the Vice President of Digital Health Innovations for the American Medical Association. Ken Cato, who's Professor of Informatics at University of Pennsylvania School of Nursing, a nurse scientist for pediatric data and analysis and at the Children's Hospital of Philadelphia. And then lastly, Jackie Gerhardt, who's the Chief Medical Officer and Vice President of Clinical Informatics at Epic and a family medicine doc, as we heard. So I'm going to go ahead and, whoops, we did advance the slides. Let's see here. So I just have a few comments here this morning. This is my disclosure. I'm a co-inventor of the Wellbeing Index. It's really outside of the information we're going to be talking about here today. So I think we all know why we're here, right? This is a reminder that the work that we've done in collaboration with the AMA, Shanna Felt, who's here in the office, has consistently shown a very high prevalence of burnout in physicians, much higher relative to other US workers. This persists even after we control for work hours and a variety of other factors. We see a big peak here, obviously 21 months into the pandemic. New data that will be published soon is good news, and that we are seeing a bit of a back downward trajectory as we have moved further away from the pandemic. Of course, this is not a phenomenon that's limited to physicians. We are here talking about clinicians, talking about all members of the healthcare team. Research that we have done, that others have done, have similarly found a high prevalence of burnout, depression, other forms of distress in healthcare workers. Doesn't matter if you're a pharmacist, a dentist, an advanced practice professional, a trainee, we see the same story, unfortunately, again and again. And just to remind us all, we are here to drive action forward. To drive that action, we have to be able to articulate the so what. Why does it matter that there's a high prevalence of burnout in healthcare workers? Well, for one, it threatens the very premise that we are all here to deliver high quality, safe, effective patient care. We know that physicians and nurses who are more burnt out have less commitment to lowering the cost of care. We know that they engage more in unprofessional behaviors, that they have lower empathy, less compassion, are less accountable to sort of holding us all to the standards of medicine. And importantly, we know that docs who have high levels of burnout are twice as likely to be involved in medical malpractice litigation suit. They're twice as likely to say they've committed a major medical error. The level of burnout in nurses and doctors in the ICU is an independent predictor of patient mortality. The level of burnout in our nurses is an independent predictor of hospital-associated infections. And obviously, there are mental health consequences. We have already talked about problems with access to care. Doctors who are burnt out are twice as likely to leave their place of employment, many of whom are not seeking another job in healthcare. If we don't leave, we reduce the time taking care of patients, which is another way that impacts access to care. And that's happening all too often as people are finding the release valve, right? Finding a way to still care for patients in our dysfunctional system. And we all know that the drivers are complex, or else we wouldn't have been at it, since 2017 or 2018 when we all started this journey together. And we blame the electronic health record, right? Myself, as a general internist practicing at Lowry, as well as many of my colleagues, if only we could fix the electronic health record. And certainly in studies of physicians, as well as in studies of nurses, we have given our electronic health record a pretty bad usability grade. But it's not all about the electronic health record. It's also simply about the volume of work that comes through the electronic health record. This is from UC Health, the system in which I deliver care. You can see the number of in-basket messages that we were all receiving before the pandemic, about 53,000 messages a month. You can see now that it's over 183,000 messages a month. There's been growth in the system, yes, but not nearly to that proportion. You talk to any of my primary care colleagues, they're on average getting between 30 to 50 in-basket messages a day, on top of seeing patients every 20 to 30 minutes. And then, of course, there are my colleagues, our colleagues who practice hospital medicine. Recent publication from Marisha Burton at University of Colorado and her colleagues demonstrating that for a hospitalist shift, they're getting 130 secure chat messages in one shift. They're trying to also hold the hands of patients, talk to families, coordinate care. So we're here today together to really talk about, can AI improve healthcare workforce well-being? How can it improve it? What could be the unintended negative consequences? How do we adapt it? When do we adapt it? Where's it gonna work, right? All these sorts of really important questions. We are having this conversation in a setting where the press is having this conversation. We're having it in the setting where the AAMC and the ACGME and the rest of the alphabet soup are having this conversation. So I look really forward to spending the day with you today as well as tomorrow to really sort out how can we move forward together to really impact the lives of healthcare workers and, importantly, the patients for whom we provide care. So with that, I'm going to go ahead and transition it over to Christopher Longhurst for his comments.
Terrific. Well, thank you for that perfect setup for a conversation today. So a little bit of introduction. I wear a number of different hats. I get to help lead the Office for the Chief Medical Officer, our IT portfolio, including our CIO and information security. And so I sit really at the junction of exactly what you're talking about, which is this epidemic of messages and after-hours work and non-reimbursed kind of clinical time that is driving our clinicians nuts and contributing to a sense of lack of well-being. And I want to commend Dr. Chris Kane, the CEO of our physician group, who along with our CEO, Patty, really undertook an effort to measure wellness throughout all of our clinicians. One of the areas where we found the highest correlation between burnout and well-being and technology use was a single question, which was, do you have somebody who helps you answer messages in the electronic health record? Because we've had the exact same experience that UC Health and others have had, which is an incredible rise in messages during the pandemic. In fact, our primary care physicians on average do get about 30 messages, and it turns out they spend 30 seconds to a minute answering each one of those messages. And so I'm going to back up a little bit to the fall of 2022 when ChatGPT was released, and a colleague of mine called and had been playing with it and feeding it patient messages off of a Reddit forum. And the responses were surprisingly good. And he called me up and said, I'm going to try measuring it, and will you help study this? And I said, absolutely. I'll spend my Christmas break ranking 200 patient questions and responses. And unfortunately, the clickbait headlines that came out of this were that the chatbot was smarter and more empathetic than doctors. And that wasn't my takeaway. My takeaway was that actually the chatbot could tee up really accurate responses that came with a tone of empathy that our clinicians were actually in some cases envious of. But I saw this as an opportunity to implement a tool to help solve this problem of the epidemic of messages. And so I called up my colleague, Dr. Gerhardt here at our EHR vendor and others, and we agreed that we would pilot this as one of the first places to implement generative AI in our electronic health record. So fast forward, April of 2023, we were announced as one of the first 2 pilots in the country, along with Stanford and eventually University of Wisconsin. And thanks to generous donation from Erwin and Joe Jacobs, we had the resources not only to implement this, but to actually measure what happened. And that's really important because that's something I think we're all hoping we can do, but don't always have the resources to actually do. And credit to Dr. Ming Tai Seal, who's sitting in the front here. Ming helped lead a group that very rigorously evaluated in a randomized QI study the impact on early adopters versus late adopters, because we couldn't get any of our primary care doctors to say that they weren't going to adopt it. So it was early versus late. What did we find? Well, first of all, it absolutely reduced cognitive burden. And that's sort of from the Journal of No-Brainers, which is that it's much easier to face sort of the edit on the screen or the copy on the screen and edit it than it is to start blank. Secondly, it did not significantly reduce time spent. So before the AI, it took about 30 seconds to see that patient message, maybe use a dot phrase, your labs are normal, et cetera. Or maybe it's too complicated a question and you say, please come see me in person or let's schedule a televisit. After the AI, now you have this 3 or 4 paragraph response. And it still took about 30 seconds to edit that response and make it sound like it was coming from your tone and send it off. So it wasn't reducing time, but it was improving well-being and reducing cognitive load. And in fact, our colleagues at Stanford who studied this at the same time did measure burnout using the standardized inventory, and they found that it decreased burnout. There was a third, though, really important lesson that I want to make sure doesn't get lost, which is when we were implementing this, we ensured that we were adhering to our AI governance principles, one of which is transparency. And we often think about that as transparency of the algorithms that are used to develop or implement, or transparency of data sets. But in this case, a really important question was asked about transparency with our patients when we were using this tool. And I'll say that my initial response and some of our clinicians is, hey, we don't have like a disclaimer when we use dot phrases, so like why does this need a disclaimer? It's still being edited by the doctor. But representatives for our patient family community said, AI is different, it's scary. And if we want to maximize trust with our patients, we should maximize transparency, and that's what we did. So anytime a physician clicks that button that says start with draft message, we put a disclaimer at the bottom that says this message was generated automatically and reviewed and edited by, and it puts your doctor's name in. I think that was actually one of the most important things that we did. That got coverage in the New York Times just last month because there are now almost 200 health systems using this functionality across the US, representing tens if not hundreds of thousands of physicians. And it's implemented in a highly variable way. Some places have done this. All the University of California hospitals have implemented and are using this transparent approach. Others have not and defended it in that New York Times article. But as we move forward with these tools to transform the way we're delivering care, because I agree 100% with Dr. Ferris that this is going to totally change the way that we practice medicine and deliver health care, I think we've got to do this in a way that not only measures it rigorously, but partners with our patients and families on how we do that. So I want to finish my comments just by sharing the denouement of the story, which is that we're continuing to roll this out and have had conversations with our nursing union because by request our nurses wanted access to this. And so it was with great interest I read a fantastic article from University of Colorado where Dr. C.T. Lin and colleagues published the effect of these draft replies, and they found actually the net promoter score in physicians was net negative. Remember, that's minus 100 to plus 100. Medical assistants, it was also net negative. But the average net promoter score among nurses was about 58. And there was a great accompanying editorial by Dr. Lisa Rottenstein and Bob Wachter where they identified that protocolized kind of situations where this AI is most likely to help, it's probably going to be the most helpful, and that it may actually help nursing workflow more than others. And so we're continuing to learn together in that learning health system on what's working and what isn't. And just over the last 12 and 18 months, we've learned a ton together in partnership with our vendor and other colleagues. And that's really, I think, the most important set of comments moving forward, is that we need to continue rigorously evaluating what's working, what isn't, because it's not a silver bullet. So thank you. Look forward to the panel.
Thank you. Hi, I was going to say good morning. It's 11:59, so it's still morning. Good morning, everyone. My name is Margaret Lozowatsky. I am a pediatric hospitalist. I still see patients a few times a month, and I am the Vice President of Digital Health for the American Medical Association, and I like to say a recovering CMIO, CHIO. I've been doing healthcare informatics for most of my career, and as I joined the AMA, my focus is on how to support physicians, because we are the AMA, we focus on physicians, in their use of technology, so all clinical technologies. And this is a very exciting topic for us as technology is evolving very, very quickly. And so what I wanted to do is take a little bit of a step back and talk about some of the research that we have done at the AMA when it comes to well-being, and some high-level thoughts on what we believe is the path forward to implementing these technologies successfully. And I really appreciate Dr. Longhurst's comments on the fact that we have a lot to learn. We are very much in the infancy of utilizing these technologies in healthcare. And so we found, as was said before, that today about 48% of physicians report some level of burnout. So it's a little bit better than it was at the height of the pandemic, but man, we have a long way to go. We talk a lot about the different forces that are impacting physicians today. And we know that those forces are impacting us on a daily basis. So things like prior auth documentation, reporting requirements, technology often being at the top of the list of what we report as the cause of our burnout, and yet we recognize that we're experiencing all these other forces through technology, and so it's really important for us to really get to the root of the challenges so that we can start to address those challenges. While we know that the user interfaces sometimes have had opportunities, we also recognize that all of these other things that we're experiencing through that technology lens may have a very significant impact on our well-being. And so we think a lot about what are the AI tools that can help, right? That's the question that we're trying to solve here. And at the AMA, we have developed this alternative conceptualization of AI. We call it augmented intelligence. And what that means is that we recognize that technology is at a place right now where we don't think it can be autonomous. So we don't believe that today an AI bot can take care of patients independently. And while we may at some point get to that place, it's going to be really important for us to understand that that clinical judgment of our colleagues is at the center of all of this, and is the reason that we went into medicine, to take care of patients. And so that, as we think about well-being, is a really critical aspect of how we look at these technologies. And we also are starting to understand which are the areas where these tools can be most impactful, as has been highlighted, and I think is really important. It may not be where we think it's going to be impactful. So we all know the in-basket is probably the number one thing we hear our clinicians say is the cause of their burnout. And yet, while we are seeing anecdotal evidence that there is improvement, we're also not seeing a time change in the time that's spent responding to these messages. And so as we continue to evaluate these tools, we're going to need to really think about where can we have the most impact. Of course, ambient has been discussed. I did want to talk a little bit about this concept of cognitive burden, and that has been brought up by Dr. Harris here, which I think is often at the root of many of our struggles, because we talked about all these forces coming at us and the amount of data that we're having to digest. I was at a meeting in DC talking about AI with a lot of leaders, and somebody brought up a really impactful statistic where he said that 50 years ago, if you were taking care of an ICU patient, there were 7 pieces of data on that ICU patient. And 7 factorial would be the combination of all of those pieces of data, which none of us could really process, right? No human brain can do that. Today, it's about 1,300 pieces of data on every ICU patient. Now, 1,300 factorial will break your calculator. And we are asking our clinicians to process that information and to make clinical decisions, which we know is not possible. And so to me, that's where the power of AI is really going to show most of its impact, is helping to decrease that cognitive burden and doing the computational work that our human brains are not able to do. And what does that look like in the clinical settings? We know that a lot of the burden is processing information within our charts. So some of these chart search functionalities that will be able to present the right information to the right person at the right time, all the R's of clinical decision support, so that when a dermatologist is looking at it, they'll get information relative to them. When a neurologist is looking at it, they'll get the information that they need. Some of these data trend challenges, so what I described, all of these data points that we're not able to necessarily trend in our heads, the power of the AI tools is that they'll be able to show those trends and to help us make clinical decisions. Again, that augmentative concept where the computer presents the right information and we continue to make clinical decisions. So thinking about these tools as a co-pilot, similarly to how we use them in other settings. I also wanted to talk a little bit about some of the challenges, and that was a question that was asked. How do we integrate these tools successfully? We know that there's a lot of potential here. When we ask physicians, and we've done a lot of research on this, and we're actually going to redo the research to make sure that we continue to stay current, but when we ask them, what are you looking for in your technology? The things that they say is they want the technology to function seamlessly. No surprise, right? Just like you use your iPhone and you know it's going to tell you what you need. They want the technology to help enable their ability to care for patients. They want to make sure it works for their specialty because we know that the needs are very different. And they also often talk about the fact that they want to see that the technology is actually helping have improvements in outcomes for their patients, because again, ultimately we're there for the needs of the patient. So how do we do this? We know that we need to be very thoughtful about integrating those technologies into workflows. And yet what we've often found is that we concentrate on the processes that we know. So when we were implementing EHRs, we said, this is my form, put it in the computer. This is the way I do things, don't mess with that. And so instead of re-envisioning the workflow and how we could potentially care for patients with these new technologies, what we did is we took the paper and we put it in the computer. We don't take web pages and put them into a smartphone without redesigning them. And yet we did exactly that with a lot of our technologies. So as we think about integrating these AI tools, there's going to be a lot of hard work to really re-envision the way that we deliver care and question what is the appropriate workflow. Do we need to have new tools for the way we document, or do we re-envision the way that we write notes today so that they serve the purpose that we think they should in the future? And finally, what I want to conclude with is the fact that there's a lot of hype right now about AI. There's a lot of excitement, rightfully so, because it has a lot of potential. And what we need to recognize is that technology is not the limitation for the changes that we are thinking about. So much of this depends on the people and the process. And it is a huge culture shift across our organizations to recognize that it is on us, all of us as clinical leaders, to really design the process that we want to have, the new re-envisioned workflows, and have technology support those rather than hope that the technology will drive the changes that we are hoping for. Thank you.
So I think it's now afternoon. So good afternoon, everyone. My name is Ken Ricato. As mentioned, I'm a nurse researcher. I spend a lot of time doing clinical decision support, I'm glad to hear that Dr. Ferris really likes clinical decision support. I'm here to talk a little bit about AI for the health workforce from a nursing perspective. I think I'm going to try to not repeat some of the things that were said previously. So there's three broad areas that I'm going to talk about that I think are really important in nursing as the way I've conceptualized it. So I'm going to talk about workload management and efficiency, mental health and emotional support, and continuous learning and professional support. And these are all areas that I want to talk about how AI is being used right now and some I call it challenges and opportunities. So workload management and efficiency from a nursing perspective, right now the literature says that nurses spend about 80% of their time doing scheduling. So you can imagine that, and AI has been successful, AI research anyway has been successful. I've done some research with a colleague named Carrie Chan at the Columbia Business School, where been very successful in being able to predict what's needed for the workforce and be able to bring that into scheduling. And so there is great promise for that. Task automation. Dr. Gard and I think we were on a task automation panel maybe 2 years ago. And there is great promise for task automation. When we think about the role of nurses in things like documentation and billing, we talked about prior authorization in the outpatient setting. It's very burdensome for nurses. To free them up to do direct patient care or other tasks. It is important, I think it was mentioned at the beginning, there is research that shows also in nursing that when nurses are free to do more patient care, their time is filled with other administrative tasks. So we need to think about that. AI is promising to do that, but there are issues that we have to figure out. Resource allocation. One of the things that nurses do spend a lot of time, and this is sometimes a system issue, is identifying resources and understanding where those resources are. There's a lot of innovative work being done with things like robots to help with that, and also scanning in supply chain management. Mental health and emotional support. So as many of you know in this room, there's been an explosion of AI-powered mental health apps and chatbots to help. The literature shows that actually is helpful in providing emotional support and reducing stress. Burnout detection, which is, I think, really exciting. So one of the things that I've tried and failed from a research perspective is how to detect burnout in almost real time. There's a team that was just published recently, I think April this year, from Mayo, led by Dr. Wilton, where they created what they call Brownie, which is the burnout prediction using wearable and artificial intelligence, pretty crafty name. Mm-hmm. So basically they just had nurses wear a watch, I believe it was a Garmin watch that would measure a bunch of physiological signals, but they were able to predict burnout. I think it's important with burnout, some of you might know in the room, that burnout is much harder to treat once it occurs than to prevent. And so I think it's important for us to think about that. And then the last category I'll talk about is continuous learning and professional support. And when I say professional support, I'm thinking about how you can support a nurse to work at the top of their license, to do nursing science. And so there's personalized training, basically competency-based training, which is it's not a new concept, but it's become kind of de rigueur these days, where AI is really good at figuring out where you are in your levels of training and providing you the adequate level of training until you get to the next level of training. And so there's great potential in that, and there's great science being done around that. Decision support, which is the way I see it, designed to provide in the clinical setting at least, support for clinicians to work at the top of their license, free them up to think, to reduce their cognitive burden, to think more clearly about what their training has told them they should be doing for the patient. And so one of the research projects I'd like to highlight is a project that myself and Dr. Sarah Rossetti, who's going to be speaking later today, have done where we actually the task was to predict inpatient deterioration, and instead of trying to model the patient and physiological changes, which we feel is a lagging indicator, once you have physiological changes, you've already started deteriorating, we actually model nursing behavior and levels of nursing surveillance to predict deterioration, and we're able to predict deterioration 2 to 3 days earlier than the deteriorating event. And so I highlight that project because we've had great results. It's under review in a high-impact journal right now, and but one of the things that were really key to it are some of the other pieces that we talk about burnout, where we take information that's already in the clinical workflow, so we don't add any burden to the nurses to add information. We've also made sure it's very explainable what's driving the prediction at any time. And so we've gotten really great results. Risk of mortality for patients lowered by 35% in the intervention group. And so we're very excited about that. And so finally, simulation-based training. That's an area. Training is something I think we do very badly in healthcare. And when I mean training, I don't mean education. I mean, as you're doing your work, continuously training people. That's something that when we talk about AI interventions, we're going to need to be able to continuously train people about the new interventions that are coming. And so there has been really great science, not just the sexy VR and virtual reality stuff, but to train people continuously. And so just quickly, challenges and opportunities, and many have been mentioned already, so I'm going to skip over a couple of them. But I think the first one I'm going to start off with is traditionally nursing has been an afterthought in healthcare. And so I think it's really important for us to make sure that nursing is at the table in every aspect in AI intervention. And that's one of the things that I do in my research, is to make sure in our advisory boards we have clinical nurses, we have nurse researchers, things like that. A strong governance, there's this idea, Dr. Levitsky talked about having AI, make sure that we're doing AI for the right purpose. I think a strong governance model, not just at the places that have strong governance, but across the country will be important. And then, so right now I see in things like in a lot of the large language models, there's a lack of clinical reasoning. And we've done some research when we think about nursing clinical reasoning and thinking about those data that are in the data sets don't necessarily represent what's happening in clinical reasoning if you're learning on EHR data. So how do you develop science to, and people are doing things like knowledge graphs, but knowledge graphs, we haven't figured out how we're going to bring those into large language models. So we need to think about how we're going to incorporate clinical reasoning. And then I'll wrap up with two things. So workforce, in nursing, we have workforce issues where we don't have the right amount of trained AI researchers, clinical informaticians, and implementation science folks. So that's something we have to figure out how we're going to do. And then the last thing I would say is, people ask me to talk about nursing, but I think we need to take a more interdisciplinary approach to these problems. Because, a patient sees a bunch of different people. And we as clinicians work in an interdisciplinary team. So I think it's going to be really important for us to figure out how we solve these problems and not think about it as, how do we get better AI? Physician tools, better AI, pharmacy tools, better AI, nursing tools, but just basically how we get better clinical tools and build interdisciplinary systems that those tools can support. So I'll end it there. Thank you.
I do. Thank you. Hi, everyone, and good afternoon. I wanted to thank my co-panelists for such wonderful remarks. I'm Jackie Gerhardt. I'm a family physician from Epic, And my background is that I did full scope family medicine at the University of Wisconsin, inpatient, outpatient, obstetrics, nursing home, et cetera, for about 8 years before starting as a clinical informaticist at Epic. And one of the first things that I get asked is, physicians actually work at Epic? And the answer is yes, but every single day we do slightly different things. And so I'm here to show you a little bit about what the role looks like and also really to be the use case queen. So we've heard a lot about the research and so forth, but I want to get very practical, very actionable on what has been used, what's been studied, and then some takeaways of what we can do from here. So to start, this represents that AI has been around for a long time, period. We've been using it throughout our daily lives, and we would be remiss if we didn't state that we're already using it in many places within medicine. Why it's jumped on the scene so recently is because of the Gen AI. And as Dr. Longhurst mentioned, ChatGPT came on the scene and our patients started using it and we're playing catch up. Just a little bit of definition and background. We've talked multiple times today of a few different types of artificial intelligence. All the rage, again, is on generative AI. But I really want to focus on both the rule-based logic and the predictive analytics that have been around, again, for a long time. Rule-based logic is something like a drug-drug interaction or a drug that interacts with an allergy. So it's something that is specifically coded within the system to help you make a decision. Predictive analytics was just mentioned on nursing, for example. So trying to figure out a deterioration index or risk is an example of trying to take information from previously and apply it to try to predict what's going to happen to a patient in the future. And these, again, are in use. And then now generative AI, really, what are the practical ways that we are currently using this within the healthcare system? So I want to focus primarily on 4 things that this can do for clinicians and for patients. So these are tasks that we have to do every single day, and they are not really what brought us into medicine, right? We're there because we want to take care of patients, we want to be able to see things and really make a deliberate decision on diagnostics and therapeutics, while the other stuff that usually takes like 90% of our time just falls by the wayside and into the background. So can that AI draft text for us, summarize things like clinical records for us, translate even, and that could be multiple types of translation. That could be from one language to another, or it could be, for example, putting doctor speak at an 8th grade reading level, which can be really helpful as well. And then task automation. So think of those 4 as what I'm seeing as the first entry points into generative AI that really allow us to do something that allows to reduce burden and address clinical well-being. So here's just a brief history of when things happened. If you're not aware, Epic at least has 297 organizations that are live using generative AI today. So this is not something that's coming in the future. This is here, and we really need to pay attention to how we research it along the way. So intentionally, at Epic, we've been developing, starting with clinicians and creating use cases that intimately help them reduce their burden. Oftentimes, we first think about putting the patient at center and everything else around the patient. But in this workforce crisis, we've heard a ton about how we don't have enough clinicians, about how they're burning out, et cetera. So we really wanted to attack that first. So I'm going to talk primarily just about doctors and nurses today. And we're going to do a rapid fire use case. Here are some of the things we've already discussed that are available now and ones that are coming. In-Basket you heard of, and Dr. Longhurst has printed a really great article on it. I encourage you to check it out. Really good research on what it does reduce and what it doesn't. Same thing with outpatient summaries. There's some good research in Lancet out of the Netherlands that goes through how that helps to summarize notes. And just a picture of what those look like. Oh, one more stat first. So generative AI adoption, someone mentioned this a little bit earlier, even if it doesn't feel, or if the numbers of decreasing the amount of time aren't there, clinicians are feeling this deeply in their bones and in their heart, that they are getting home for dinner on time, that they feel less burden, that it's, in some cases, feels like they're better connected with their patients and so forth. So as we research this, don't forget there's the quantitative side, but also the qualitative side that really is impactful. All right, examples. So first, ambient notes. This is what a typical note template looks like with when you're seeing a patient in Epic. You then can take any EHR, or excuse me, any vendor of voice recognition and put that in to be embedded within the EHR, and it will write you a note. This I've seen in my own practice to be able to actually catch things that I didn't notice before, and so it actually is helping me in my own patient care as well. So win for documentation burden, but also win for really capturing the voice of the patients. And patients do feel like they're not only listened to more because you have more eye contact, but also that when they go back and look at their notes, because remember, they are a consumer of the record too, that they really feel like their voice was heard. Next example is summaries. This is one example in the outpatient setting where pulling together that complexity of care that we heard about earlier and making sure that the labs, the notes, et cetera, are all brought into one place and that we are being transparent about it. You see there's a little AI symbol in the upper right corner. So that helps the clinician know that AI behind the scenes is helping gather this information for them to then take action on, reducing cognitive burden and so forth. With the UX, you need to make sure you're doing the right UX for the right person, so the hospital summary looks different than the outpatient one. It includes things in the last 24 hours, recent notes from the past few days, ones that are specific to this patient. And then in-basket responses, so the goal here is to decrease the cognitive burden. And as we mentioned, some of this is really just trying to get through the in-basket and increase your ability to get back to seeing your patients, since that was something that really increased during the pandemic, and we see it as yet another burden. And how can we, instead of seeing it as a burden, have the burdensome parts taken away so that we can really focus on the patient care pieces that are there? Coming next and under development is discrete documentation, not just in notes, but also in orders. So you see here that I might have a conversation with my patient about their diabetes, and then it'll show the change in the metformin dosing and even a referral to nutrition that I might have spoken to with my patient as part of their plan. Moving on to nurses. So same thing, they can use in-basket, and as Dr. Longhurst mentioned, RNs have really been seeing great promise with this. And then there's also a few others that are coming up, the AI text assistant, inpatient summaries, and end of shift notes as well. And I'll just give you two quick examples. The first is that end of shift note. So this is live today at multiple different healthcare organizations. And what this does is it brings together what a nurse would typically type at the end of the shift over and over again in the very same format, and brings in discrete information from the chart so that they're not going back and flipping from one screen to another and referencing that information. It's instead brought forward for them. And then ambient flow sheets. Ambient is not just for physicians. Nurses also can use it at the bedside. This is one good example of actually using something that is not AI, so like a macro, for example, for a flow sheet, and how that can actually be a solution in addition to or instead of something that is an AI solution like ambient. So as we've been piloting this in the field, oftentimes nurses don't find themselves explaining their plan of care or explaining and doing sort of verbal discussion back and forth. They're used to documenting in flow sheets. So how do we make sure that we're developing the right tool for the right job within AI? So I'm going to, before your lunch break, I want to add 5 different takeaways that I think I heard from our panel, and I think could be things that NAM could definitely do in the future. So the first one is use the right tool for the job and make sure it has the right fit. So we heard about automation versus AI. Definitely make sure before investing in AI and spending the cost that it might be that you don't already have a tool that you can use that could automate something that might even be better. Second is choose and create interventions and research while you're going. we as an academic community oftentimes think about doing research first and then implementing something afterwards. And we heard about implementation science today. And I think all of us feel that implementation science is so critical to making sure that you're not just putting a technology into place, but you're actually making it adaptable to the people that are using it. Third is emphasize governance and transparency. So as you know, many shiny objects will come to your door and you'll have to decide which ones to choose. If you have a good governance structure about what it is that you're looking for and your key priorities, maybe it's clinician burnout, and that would be one that is well studied for you to have as the core of your governance, and then what AI tools actually help benefit that. Then fourth is clarify your message. We've heard, and I can speak to it from the side of both the health system and the vendor side, we've often heard conflicting feelings around seeing patients. What I mean by that is, on the same breath as saying, we feel burnt out and we just want to get back to patients and see our patients and look them in the eye, we also hear things like ambient that say, yeah, but I don't want to just see one more patient. And if you think about those two messages and combining them together, there's a little bit of a dissonance there. So how do we as a community figure out how to communicate on our needs within using AI and on our needs within well-being? And then lastly, number 5, be ready for more. The examples that I just gave today are very much use cases that are pretty simple and don't have a ton of risk. And I think we heard that really one of the opportunities here is to have clinical decision support and to potentially help decrease misdiagnoses or increase improved treatments. And so that's coming, and I would encourage us to start with these types of use cases that are perhaps lower risk as we are anticipating further ones. Thank you.
Thank you very much to all the panelists. So for those in the room, we're going to keep you hostage for about 20 minutes for a Q&A. We're not quite ready to go to lunch. And for those of you who are on Zoom, there's a mechanism for you to enter your questions, and then the staff here will be sharing those with us. As you contemplate your questions for the esteemed panel here, I thought I would kick it off with one of my own. We've heard multiple different ways of applying potentially AI through the lens of both inpatient, outpatient care, various different healthcare professionals. And, and I think one of the things that Dr. Gerhardt just mentioned too is this issue around the reality of what's the financial model, right, to pay for this. I think that's sort of one of the elephants in the room that we need to deal with. Because margins are shrinking in hospitals, many hospital systems are actually in the red. So how do we become that early adopter that we heard about from the plenary? So I'd like for each member of the panel here maybe just to address this question about what's the financial model for incorporating AI into healthcare. And after that, open it up to the floor and to the Zoom audience for additional questions. Thank you.
Anyone want to go first?
I can start, and then I know you'll all add on. So,
pile on.
Yeah, please pile on as much as you can. This is a huge issue, and it's definitely an issue around well-being as well. There's often a really good narrative around what does it look like to see one more patient, or what does it look like to decrease your population health costs, things that are very much hard ROI. And there hasn't, in my opinion, been enough discussion around the ROI of clinician burden itself. I think there have been multiple discussions around what's the cost of losing a physician or a nurse, what is the burden of having them have decreased safety when they make a medical error, and so forth. And so I think putting much more discrete financials around that is important. Then that's the general topic. Then more specifically, each one of these AI models does cost money. There's a cost and a compute factor to each one. And so as you're looking to implement it, it's really using the right tool for the right job that is actually going to be cost effective. So there might be something, again, that's not AI that you could use. And thinking about the end user is key. If you're trying to help improve your physician well-being, what tools are you giving them? What about the nursing well-being? It's partly about efficiency, and that's one hard metric that we can get. But it's also about things like cognitive burden and decreasing the load and making sure that you're actually getting good care to the right patient at the right time. So figuring out actual dollar signs in front of that is important. And the last thing I'll say, every single one of those 297 organizations that I mentioned before that's using Gen AI had to have a use case where they went to either their board or their executives and said, hey, we want to implement this. Here's the ROI behind it. And so I would just encourage you that people have come before you. Make sure that you go ahead and use the research that's there already.
Yeah, so I would add to what Dr. Gerhardt said similarly that there's a woman named Jane Engelbright who was the CNE, Chief Nursing Executive at HCA for a while. And I saw her do a magical thing I'd never seen anyone do before, which was get a large healthcare system to put lots of money into nursing to do computational-based research. And what she did was literally just a back-of-the-napkin calculation of how much you're spending on nurse turnover. And so to Dr. Gerhardt's point, I do think that there are ways that we haven't thought about how we spend money in healthcare, that we need to sit down and think about it and operationalize it. And I'd also add that my background is in data science and software engineering, so I know people at some of these fancy AI companies, and they have problems figuring out how to think about how to charge for these things as well. So I do think that some of this is just having issues of trying to think about new paradigms and how we do it as well, that we need to figure out, that we're not so good at in healthcare as well.
So absolutely agree with all the points that have been made. The way that we think about this at the AMA, and we've put a framework together we call Return on Health, is thinking through what we call the value equation. Often when you present this to your board or your E-team, the first question is how much does it cost? And of course, cost is part of the value equation. And then there's all of the other aspects. I think about it in terms of the quintuple aim. So the clinician experience, the patient experience, quality outcomes, and then of course, impact on equity. And so as you think about each of those buckets when it comes to whatever technology that you're evaluating, we've been talking a lot about ambient. One of the last things I did in my CHIO role is work on signing the contract for our ambient vendor, and that's exactly how we presented it. And that was the process we used as a healthcare institution. In our governance model is for all technologies, we needed to evaluate it in all of those buckets. And it's gonna look different depending on what problem you're trying to solve. But if you think about the clinician experience and you start to measure things like turnover and clinician satisfaction and all of these other aspects, then you start to build a more robust process for evaluating your technologies, and you can demonstrate the value. And the final thing I'll say about that is we are often not great about measuring baseline. And so I would encourage you whenever you're presenting this to recognize what your current state is, so that as these technologies get implemented, we actually are able to show the impact that they had in each of these categories, and we're able to demonstrate the value.
Thanks for the thoughtful comments. I'll just add that I completely agree with Margaret that on the local level, it's about the return on health and measuring the quadruple aim. But I think at a national level, somebody alluded to solving the right problem. And it reminds me of a 2018 article we published looking at the length of notes in the US and across other countries. I see our colleagues from Canada here, where the median physician note length is about 600 characters, compared to the United States, where the median note is about 4,000 characters. So what have we done with these AI scribes? Well, we've recreated sort of the old model of let's get a fully compliant note that we can use to bill every CPT code under the sky. And it works, but it doesn't help us solve the root problem. And so this is a generational opportunity for us to think about how we change this. Dr. Seema Verma, when she was leading CMS in 2018, actually started an initiative called Patients Over Paperwork, where it was a reduction of documentation required for CPT billing, which was a good start, and it cited that paper that we had written, but I think we have a long way to go. Dr. Ferris mentioned this company that spun out of Stanford 10 years ago, helping to prioritize children with autism for services. And I'll tell you as an advisor that the technology works really, really well, and the company is going underwater because there's no financial model to sustain it. So we really have to rethink our health economics and incentives so that we can take advantage of these new technologies to solve the problems that do matter.
We'll go ahead and take questions from the audience. Is there a mic that'll be passed around? Wonderful. There's actually the lady in the back in the green had her hand up first. Thank you.
Yes, she is.
You as moderator, because I could never pronounce your name. But you did mention about elephants in the room, and I have Alzheimer's memory. So one of the things that I'm going to be asking, not to get an answer right now, but people to think about, you can talk among each other and with the panel. So in looking at the doctor-patient and RN-patient collaboration in delivering care, because that's important. One of the things that one of our big healthcare people started about, 25, 30 years ago, call centers. And call centers were good ideas, in my opinion, on paper. But how can AI address the issues associated with call centers? Health insurers practicing medicine. I'm not talking about anything about the murder that just happened, because that's completely different from what I'm talking about. Practicing medicine without a license. And peer-to-peers are being done by non-clinical people and taking up a lot of time with peer-to-peers from non-clinical people. How can AI address that issue? And finally, something that everyone that has had a medical record, whether you're a physician or patient, correcting errors in the medical record. So those are things that I would like us to think about and talk about amongst ourselves and with the expert panel. Thank you for your time.
A lot of questions.
Anybody want to take on one of those?
You want to go?
I feel like I've been starting. Does anyone else want to start? Otherwise, I'm happy to.
You can start.
All right. So I'll take on the different three. So starting with call centers, I do think AI is already helping with this quite a bit. So you can imagine that in many other industries, there's automation. So automation is first, and then there's also chatbots, which you've probably seen and used with many of your other apps as well. Many organizations are already using chatbots as part of their call center infrastructure, and it's going to be even coming more so. So for example, right now as a patient, you can use your phone using SMS text message to send in a text saying, I need to cancel my appointment, or I would like to see my physician. And then the chatbot can respond and say, oh, that's really nice. It looks like there's time next week, Tuesday. Does that work for you? Press 1 if yes, 2 if no. And so this stuff already is existing and really helping patient care. I think it's going to become even more intelligent as the models improve. As for health insurance, that does have some AI in it. We've seen some drafting of things like denial letters and so forth. But I actually think that's one, back to the viewing this nationally. I think that's one that we can solve even before using AI or potentially even without AI, in that if we can just come up with a way, at Epic we call it payer platform, but a way to share the message that this chart says with the insurance company so that you don't have a denial or you don't need a prior auth in the first place. Just that information sharing back and forth can really be meaningful even without using AI. And then for correcting errors, yeah, I really think AI is the future for this. I am humble enough to know that I, as a physician, am very human, and that, to the points made earlier today, I will forget something that I've been taught. And I'm hopeful that as we go forward in diagnosis, treatment, et cetera, that AI is part of the role that we are playing and doing for every patient, because they're going to use it themselves. So I'd like to be part of that care team that helps them use it.
Thank you. Anybody want to add anything, or we'll take another question here? Let's do one more from the audience here in the room, and then we'll see if there's any questions available online.
I have two quick unrelated questions. Great panel discussion. Thank you. A comment came up about refining the business case. Do you know if anybody is doing that work, that, we can have one calculator that, decrease burnout by 10%. It translates not just to decreased nursing or physician turnover. We, from studies, the quality and safety outcomes improve, which are attached to this sort of financial improvement, patient experience, discretionary effort in terms of our views. I think that would be a real, great opportunity when we're pitching these things. And then unrelated, I'm not very familiar in Louisiana with the unionization movement. I was just wanting to get a sense, do you sense whether that is hindering experimentation with low-tech, high-tech models of care within nursing, accelerating, or no difference at all? So, thank you.
I can start. So I live in New York and worked in New York, so I'm very familiar with the union movement. I would say that it's hard to say because it is highly variable across the United States. I do think that what I've seen just in my personal research is that the union movement has allowed for people to pause and think about some aspects. We talked about some of the deleterious possible side effects of bringing in kind of private equity and things like that, and more business into healthcare. And I think the union movement has helped with that. I have also seen on the other side where research and innovation has been slowed down. So I think it cuts both ways, basically.
Yeah, your second question about labor impact, I think, is actually very, very pertinent. At the recent Chicago meeting we were at, you could almost divide the room into how quickly they were moving based off of feedback from labor and whether or not they had organized labor concerns. And Ken, your point's well taken that sometimes slowing down and considering carefully is the right approach. I think one thing we haven't talked about on this panel, I'd love to hear about the rest of the day, is the importance of retraining our workforce. Dr. Ferris gave the example of moving from 300 to 150 coders at one physician group, and the implication there is 150 people now need new positions. There was a previous question about the call center. And I would venture to guess that in 3 to 5 years, we won't have call centers that are staffed, exclusively by humans. There'll be a first call resolution of 100% because everything will be answered by a voice-assisted bot. But the implication, again, is that we have to figure out how we're going to retrain that workforce and make sure that there's opportunities for them to help in different skills and different positions. So this is a really incredibly pertinent. I would even go as far to say that Dr. Ferris predicted, and I agree, that over the next 7 to 10 years, practice of medicine is going to change substantially. And I would challenge the hypothesis that we'll need as many primary care physicians. It may be that our mid-level providers with augmented intelligence are operating at the level of the best primary care doctors. And so we may need to rethink how we're educating our future clinicians and workforce as well.
And I'll add specialists too. I don't know if we're going to need as many of those.
Are there any online questions?
Just shout it.
Yeah.
So just to build off of that training comment, a question asking the panel to provide their perspectives on the roles and responsibilities of health profession schools and faculty to prepare future clinicians to optimize AI.
I can jump in. I think it's been stated by several people that we're going to need to absolutely provide training for all of our colleagues. There is a lot of fear that AI will replace us, and as one of my colleagues always says, I don't think AI will replace us, but doctors that are not fluent in AI will be replaced by doctors who are, because it is going to be an integral part of how we deliver care in the future. And there's a few opportunities. First of all, we're going to need to have some very clear education for all of our trainees, but also for all of us that are out of training. This will continue to evolve, and we will need to understand maybe not the inner workings of how every AI model is functioning, but at the very least how to interpret their output and how to integrate it into our care delivery, and how we change the workflows and the way that we see patients. And then there's also a huge opportunity in medical education, which we talk about a lot, because AI is, as was stated, very good at really understanding where people are at. So having precision education for our trainees that is tailored to their needs and addresses the gaps in their training will be a very important concept as we move forward. And as we think about the future world, we often talk about this education and practice being intertwined together, where we will continue to learn and obtain new skills as we see patients.
Yeah, I would just add that I think one thing that I've seen in my travels is that from an educational standpoint, we'll need to know how to think more strategically about AI, and it's not always. The answer is not always having more AI expertise. So I do think that is something from an education perspective we need to think about.
I'll just add, Dr. Lozovsky is absolutely right in thinking of all the different parts of medical education. I think oftentimes we, depending on who we are, we center ourselves on maybe undergraduate medical education or thinking about continuing medical education. But 2 weeks ago, there was a Macy Foundation event where it was a closed meeting, 50 people, top educators and boards of medicine, that we really came up with a bunch of ideas for how to reimagine medicine education, just like we're thinking about reimagining medicine in the future in the next 10 or so years. So look for that, because I think that'll be a good piece to see.
Great. Well, we're at time. Sorry we didn't get to everybody's questions, but at this point, we will break the live meeting for lunch. Thank you.
Welcome back. I'd like to offer our welcome to this panel to all those of you in the room and those online. My name is Laura Adams. I'm a senior advisor at the National Academy of Medicine and the Leadership Consortium, and it's my absolute pleasure to introduce the panel today that's going to be focusing on exploring use cases where applications of AI have demonstrated clear or promising benefits for healthcare worker well-being. I think this is going to be an incredibly interesting and engaging panel. I had the opportunity to prep with each one of these, I think, really informative and brilliant thinkers today. So this is going to be a treat for you and for me. I was really struck by the conversation this morning, how we were talking about the complexity. Dr. Ferris, I think your overarching remarks were the perfect framing for the day, and certainly for this particular panel. And thinking about how many decades ago that David Eddy's quote that the complexity of modern medicine has exceeded the capacity of the unaided human mind. And he said that decades ago. And just thinking of the astonishing complexity that's happened since then, it really sort of blows me away. I should start with my conflicts, which are, I sit on the board of T2 Biosystems in Boston. It's a therapeutics company. TMA Precision Medicine, also in Boston. That's a rare disease diagnosis company. Inflamatics, a Silicon Valley-based company that specializes in transcriptomics and host immune diagnostic response. And I also sit on the Organization for Economic Cooperation and Development, the OECD's Global Expert AI Panel, and advise that group. So I'd like to just offer a few framing remarks before we have the opportunity for you to hear from Christine Olson, Cece Hu, and Greg Springen about their perspectives on the topic at hand today. A couple of things that I would just think are really important to consider in the age of AI. We talked about it being around for quite some time, and I think Jackie's absolutely right about that. But we do know that there's something different afoot. Without question, there is something different. And I think that what has been afforded to us now, or what the difference is with generative AI, I think there are 5 things that make it really different. The first is the speed with which it's evolving. I think it's almost beyond comprehension now how fast these systems are improving and getting better. And anytime someone points out a limitation or a complaint about AI, response is always, at least in my head, for now. It's limited for now. I also think that we do a lot of comparing AI to perfection when what we ought to be doing is comparing it to today's performance. The second of those 5 things is the scale. These things are incredibly easy to scale. When we think about traditionally looking for demonstration of value or some sort of or research evidence to come out before we deploy something in healthcare, I think those days are somewhat over with AI, at least what we've seen with the application of AI. I've had the opportunity recently to visit places where I don't usually interact. I usually interact with large academic medical centers, but I went out to places like Appalachian Regional Health in Lexington, Kentucky. I went to see South Bend, Indiana, and Beacon Health there. I went to Santa Barbara and looked at Cottage Health and had a conversation with them. Spent some time also with Bryant Health in Lincoln, Nebraska. All of these different places. And what I can tell you is they're not waiting for a p-value. They are moving ahead with implementation. And I was expecting to see somewhat greater digital divide than I saw. They were putting in diagnostic, they were putting in things that were clinically relevant, as well as those things that were administrative. Obviously, ambient listening was a big part of that. So the scale is something else. I'm just watching, for example, I was watching one of those organizations putting in something for reducing patient falls, because I have a particular interest, Chris Longhurst and I do, in improving patient safety, and watching them use technology there that can look at a patient about, 15 minutes after their admission and be able to detect whether they have usual movement of that particular patient or whether something looks like it's going to become a patient fall. They alert staff to that. And I'm watching them, and they were talking about the challenge they had with sitters, where they were deploying and trying to hire all these different sitters. Can you imagine a job like that, to sit at the bedside and watch someone to make sure that they don't fall? 24/7, 365, you need them. You buy that system once, that AI system, you can deploy it all over your health system over and over and over again, and at a very reasonable price. So when I start thinking about the scale and ability to scale, the other is the ubiquity. We talk about medical records and other digital health interventions that we've had in healthcare, and there have been many that super promising and have met a good deal of their promise, but they were in one particular area. I really don't think that there's any aspect of healthcare that AI is going to leave untouched. Any aspect. So its sheer ubiquity is something that we think about with the challenge of how do we find evidence for all the different places it's being used. I'm not sure that we can. So there's so many paradigms that are being challenged here. The fourth is the democratization. We've talked about it today, that if you have a smartphone, you've got access to the most powerful large language models in the world. And so do our patients. And I watch the hashtag patients use AI. That's ePatient Dave, and if you don't know ePatient Dave in that group, you should meet them. They are constantly talking about how they're using AI. I was at a Harvard conference, Rebecca and I were there, We were watching a mother up there with a 7-year-old who was kind of rambunctious and running along the stage and getting on the chairs and all of that. You'd think that would be very disruptive. And we were celebrating that disruption because that mother was telling us a story of 17 different clinicians, many years, and the inability to diagnose what was intractable pain, tingling sensation, almost a numbness. That child was almost incapacitated from something that they couldn't figure out what was wrong with them. And the mother finally, out of exasperation, loads it up into GPT, the entire record for that child. It doesn't say what it is. It just says you might want to consider. The first thing on that list was tethered cord. So that child's spinal cord was abnormally tethered to when it shouldn't have been in that child's spine. The more the child grew, the more it stretched the spinal cord, the more it caused those symptoms. Well, she made a beeline to a pediatrician in Michigan, and a few weeks later they had surgery, and what we saw were the results of the successful surgery. That child returned to being disruptive and rambunctious, and much to our delight. So we're watching this phenomenon. They're getting out way, way ahead of us. I see every single day, Dave runs a blog, and he puts things on there constantly about how patients are using AI. Part of our project at the National Academy of Medicine is a code of conduct project. We were asked by a lot of our National Academy members, look, there's the good news is here comes a tsunami of AI, so guidelines, principles, frameworks. Good news is everybody's developing one. And the bad news is, same. Everybody's developing a set of guidelines, principles, and frameworks. Can you please do a scholarly and diligent look at all of these and tell us where that we are in strong agreement, where we've got inconsistencies, and where there are out-and-out gaps. You can look at the Code of Conduct paper. I'm the lead author on it, and we published it in March of this year. And that paper will do our final capstone coming out in 2025. But what we did there was call upon complex adaptive systems. We knew that principles, frameworks can sometimes be very long and very complicated. The principle sets can't be more complicated than the problems we're trying to solve with them. So what we wanted to do was come up with a set of very simple rules drawn straight from complex adaptive systems, where simple rules guide very complex behaviors in nature. And so we came up with just 6 simple rules, and I was struck by the 3 of them that I think are most germane to our conversation today. One of them is to protect and advance human health and human connection as the primary aims. Not all AI is directed toward that, and we think that that's why it was critical to put it into the Code of Conduct. The second is to engage people as partners with agency. In every stage of the AI life cycle. What we mean by agency is the ability to affect decisions and the ability to affect outcomes. We heard today that was one of the big mistakes we've made in technological developments in times past, is we did not include patients, nor did we include the clinicians and healthcare workforce. And the third is to renew the moral well-being and sense of shared purpose to the healthcare workforce. We have so much promise ahead of us with AI, but if we think we're going to realize it with a demoralized workforce, I think we're wrong. And I think that you probably share that same sense. So in framing this conversation too, I think that while we'll be talking about the effect of AI on clinician well-being and where we're seeing real promise that's coming out of the evidence, we also want to just spend one moment thinking about that bigger picture, Dr. Ferris, that you painted for us today. I was thinking in my mind about the disruption that I have been watching. This idea that our incumbents are being disrupted has been going on for quite some time. There was a time when Advil and Claritin required a prescription. You had to go to the doctor to get it. You don't anymore. And as I describe a couple more of these examples, please recognize that everything I say is going to be a loss of revenue to the delivery system. So there was that loss of revenue. You could get your pregnancy test, you can buy that now, do your own pregnancy test. You used to have to go to the doctor for that. Now you can get your birth control pills, excuse me, over the counter. There was also, when I think about our rapid development of AI technologies, drug development's one of them. I think that if I were a healthcare system, I would be looking upon Ozempic and others in that same class as competitors. Because if you have a big bariatric surgery program, if you've spent a lot of your time building up your capacity to deal with these metabolic diseases that are outcomes of obesity, I think there is going to be some disruption going on there. Feels to me too like we're going to be seeing some disruption relative to the idea of, there was a paper published, and I don't have it off the top of my head, but it was a description of the movement of big tech into the clinical areas, into our delivery system, and they refer to it as digital colonization, where they come in first and offer technologies that the health systems do not have on their own, so the technology advantage. They come in and they get access to the data, whether that is through agreements or direct access to the data. They offer up then insights back to the health system based on that data, further entrenching the partnerships and the dependencies. And then fourth, they begin to develop innovations that in effect can then disrupt the delivery system based on all the things that they've done in partnership with that. I'm not suggesting anybody's greedy or avaricious or evil, but I do think that we have disruption going on. And it feels to me too like the consumer movement. I do watch them. It used to be that things like direct to consumer wasn't so much in the area of healthcare. Now, when you think about Apple's newest release of their AirPods, and it'll do the hearing test for you, and it will calibrate your AirPods so that it can correct your hearing deficit that you have. And $250 for that versus the $6,000 that it takes to get high-end hearing aids. That's just the start of it. A colleague of mine is developing a patch to be able to put on a child's head at home with mom to be able to detect, and dad, to detect an hour in advance of an epileptic seizure. What parent wouldn't want that if you have a child with epilepsy? And on and on and on. The direct-to-consumer movement is a very big one. So with all of these things as sort of the backdrop, I think that at the basis of all of this is how accepting our clinicians will be, and whether or not this technology that we're looking at and examining today really has the kind of positive impact on them that we're hoping, or has it been just the result of a really pretty successful marketing opportunity. I think we're seeing evidence of real benefit. So I want to ask our panel to begin. I'd like to ask each one of them to make their own set of remarks, and you have their bios, of course. And then we do want to open this up at least by 2:15 to your questions, because we think we get some of the richest and most effective questions from you. Thank you.
Great. Well, thank you, Laura, and thank you to the National Academy of Medicine Committee for the invitation to be here today. I'm Christine Olson. I'm the Chief Wellness Officer at Yale New Haven Health, and I am here representing wellness as a Chief Wellness Officer, but also have the pleasure to also represent our digital health team, who's doing amazing things, and to be able to tell you what they're doing as well. My remarks are, I often think of Dr. Donna Bedian of Health Services Research thinking of orienting ourselves to what goes on here. And we think about our never losing focus of our aim of providing cost-effective access to safe, high-quality, patient-centered care by great, high-performing individuals, and that patients want access to their trusted providers. They want time for them to educate and explain, and to be able to have informed consent and shared decision-making. And we need to have the time, but also the opportunity to facilitate that kind of conversation. And when we think about the well-being of our professionals who are in that seat, in that therapeutic alliance with that patient, they want to be able to have some stewardship over those resources, to have the latitude of control in that medical decision-making with that patient and practice management, to be able to get that result, that high-quality result that that patient is looking for. And how do we support with these technologies and AI now to be able to support that mission? And when I think, what can AI do? I would say AI by itself can't do anything. It's the people and the mission that motivates that AI. And I think the most important message that I would like to pass along today is that it's who's at the table and what's the motivation, and how do you become value-aligned and mission-centered in making sure that the AI hits the target to get the kind of healthcare that we would like to create. And I'll just talk a little bit about the collaboration that we have at Yale School of Medicine and Yale New Haven Health. So our Chief Digital Health Officer is Dr. Lee Schwam, and he is putting together a lot of advancements in technology with the idea of improving the well-being of the workforce, and it's that orientation that makes a big difference. Then with our wellness assessments, we look at how are our digital technologies functioning to serve the purposes of delivering that care for our healthcare professionals. And then we correlate those experiences. Does it have the features that you need? Is it serving the purposes it needs to serve? Is it easy to use? Is the time documentation, et cetera, et cetera? And then how do each of those correlate with, would you promote the practice here? Would you be retained here? Would you promote the care here? Are you professionally fulfilled? Are you not burned out? And these type of questions that are really important to each of us in the seats of providing that care, but also to our organizations who are looking to create the platforms that support and retain top talent, as we have at Yale and want to recruit. So what we do with our wellness surveys, and we did this project with our CMIOs, Dr. Alan Shao and Dr. Neetu Ketsup, we looked at these things and how they correlated with wellness to find those hot spots. Where are those opportunities, and then rank ordering our specialties to find out where the opportunities are. What else do we do to partner to make sure that we're driving those technologies to what they need to do? We take that wellness report, which is like a Rorschach test, to those specialties and say, what does this mean to you? And what you find out, the digital technology interpretation to each specialty is very different from specialty to specialty. So what we can do is really tease out what our work is for the organization to create that kind of platform. We also have two-way communications that we are working on that allows someone who has a need to be able to say, what is the need, what's the magnitude and urgency, what's the plan you'd like to do to address that, and how does it affect the patient experience, quality, safety, access, cost, and the professional experience, and how would you carry that out in a way where you can bridge the clinical model and the business model to do that. So these create our opportunities. This creates the inventory of the types of things that technologies can improve. And then when we one of the things Dr. Schwam rolled out is a bridge for ambient listening and note documentation. And so what, with permission of Dr. Tina Shaw here, with the bridge, what we did is we aggregated 6 institutions to take a look at how was that working to improve the experience. And we found that it's definitely decreasing the task load index, as we've seen. We see that it is decreasing the time of writing the notes after work. We do see that it is increasing the focus time with your patient, and that it is decreasing burnout. And you can imagine that even if it were to take the same amount of time as we've been hearing today, that it's a very different experience when the two people are in therapeutic alliance having face-to-face conversation instead of interrupted by that digital interruption, and to be able to rest and recharge and come back from work. So I'll wrap up that point with, it's so important, the partnerships that we've been hearing today and making sure that people have voice and agency to be able to express what their needs are in trying to meet the quality and that patient experience, and that they have a seat at the table, because it really shapes how that technology improves the experience. Thank you.
I hope this works. Oh, yes, it does. Good afternoon, everyone. It's such an honor to be here. Thank you for the organizers. Thank you, Laura, for having us. My name is Cici. I wear 2 hats. One is my entrepreneurial hat. I'm a co-founder and chief well-being economist at Atlantic. We're a mission-driven company, and we use machine learning to predict and prevent clinician burnout and turnover. I also hold a research appointment as a labor economist at Harvard University's Center for Labor and the Just Economy, where I've been working on a few grants looking at disruptions to the labor market, particularly around technological disruption of AI on the US labor market. We've been very fortunate to have a few grants, one of which is from the National Science Foundation. I'm very excited here to share with you a new methodology that we developed working with a few health systems actually in the audience, looking at measuring interventions at scale using machine learning. And so just to set a bit of context, we have interviewed more than 140 health systems across the country. Many of you actually sit in the audience, so thank you so much for all the feedback and lessons that you have helped us grow and learn. What we found is that in alignment with what the literature does, when we come to measuring interventions, we use surveys. And surveys are really standard practice, but they're not without their limitations, right? So surveys are, one of the key limitations that we have is something called the non-response bias. So non-response bias, for those of you who are not as familiar, it basically occurs when your respondents and the non-respondents, for some reason, they're systematically different from each other. Meaning, whatever data you collect, whether it's before an intervention or after intervention, should not be generalized to the people that you're trying to make decisions on for the non-respondents. So there are many reasons why people don't respond to surveys, right? One of the key terms that our health system partners use is the silent sufferers. So these are clinicians who are overworked, overburdened, and they really just don't have the capacity to answer surveys around, different intervention ideas or even measuring interventions. Now, the other reason could also be trust or value misalignment with organizations. So if you ask them, hey, we're thinking of rolling out this intervention, is it gonna do anything, and if they don't believe that anything is going to happen in the long run, they're not going to respond. So in our latest research paper that we're publishing, which is under peer review right now, what we found is that non-respondents are between 3 to 9 times more likely to leave. They are between 15 to 30% less productive, and most importantly, they have very different risk drivers or leading indicators of well-being. So what does this mean? It means that we really need another way of understanding and gathering data on the people who are not necessarily going to engage with you. So to address these problems, what we are proposing here is a new way of using found data that you already have in your health systems. Things from data from your HR system, and what we can do is to use the found data to do 4 very cool things. I'm going to lay those out and hopefully review interesting insights for you. One of the things that we can do data that you can use machine learning to predict turnover probability for everybody without asking anyone for additional surveys. So with that information, you can see the before and after. Did this particular intervention reduce turnover risk over time? And this would be available for everyone. The second thing that you can do is we have collected 100 plus different well-being metrics and work environment factors in order to build these predictive models. You can actually do that with interventions to look at the before and after of all of these metrics. So that's the second. So did the scheduling change actually increase the time to spend with patients? The third piece, I think, is often, we kind of touched on it a little bit today, is we can start understanding the unintended consequences of interventions and policies. And by that, I mean, often policies, as an economist, we know that you often haven't thought about a particular impact before, right? Because you have 100 plus of these work-related environmental factors that you track on a monthly basis, you can actually start testing out the before and after on all of these metrics and over a long period of time too. And the last piece that we can do, we actually discussed a little bit, is translating all of the found data into a before and after calculation, cost calculation, doing a cost and benefit analysis using we actually developed a system-specific calculator, economic cost calculator, to look at intervention effectiveness in terms of the cost and ROI piece. So I'd like to share a preliminary study that we have done using the approach that I just outlined. We looked at one intervention in particular. What we found was 2 very interesting things. So we tested out whether this intervention worked on 50 plus of these metrics I was talking about. So we hypothesized that it was going to work on a couple of metrics. So it did actually increase time spent with patients, but it actually, the effect was only around prominent for 6 months, and 12 months after, it just completely waded off. So having this kind of infrastructural data set up is very important to give you that sort of time dimension of interventions and start thinking through, oh, how long should I be, like relaunching the intervention maybe, if there's a lagged effect, or how, maybe it will take some time for an intervention to be actually effective. The next thing that we found was actually this unintended consequences piece. So we hypothesized 4 different metrics having an impact, but only one of them worked, and then 2 other ones completely we didn't think about. Actually, there was an effect. So having this kind of, again, using machine learning and having this scalable way of collecting data, it really starts to build infrastructure for you to analyze interventions in near real time and also at scale. You have multiple interventions going on all the time. If you have an infrastructure set up like this way, you can actually start to look at before and after rapidly and frequently. So again, the last thing that I want to say is basically to summarize, what we're advocating for is another non-survey-based approach to measuring intervention effectiveness and having this capacity to support decision-making around interventions. So thank you.
Good afternoon. Good afternoon, everyone. My name is Greg Springen. I am the Vice President of Clinical Informatics at Epic. I am a nurse by background. By way of disclosures, that's the only thing that I have to disclose, is that I work at Epic, and many of you have heard about some of the tools that we have available, that we've developed and sell to the market today. This conversation has been fascinating so far through the whole day, and the perspectives on this panel. So many thanks to the National Academy of Medicine for the invitation. I would like to lead with kind of 3 remarks or 3 key topics. I think we heard this during the first panel, and that is that AI is here, and many organizations and many clinicians throughout the United States and around the world are using it day in and day out in their clinical practice. In nursing, we often talk about the development of a nurse, and we characterize it as moving from a novice to an expert. And today, I think we need to be asking ourselves, what are the components of expert nursing practice that are related to technology and AI? We can't have nurses who are working at the bedside who are expert clinicians and novice in terms of using technology. There's an expectation from patients, from health systems, from the nurses themselves, and the rest of the interdisciplinary care team that we are proficient and that we are somewhat expert in using technology. The second thing that I would like to kind of remark on is we have talked about a lot of different applications of AI and the potential for those that exist out in the industry, whether that is large language models or something else. And I would venture to say that most people are somewhat more comfortable with the consumer applications of AI than they are with a lot of the clinical applications of AI. And so I think it begs this question of how do we create the space and the same level of comfort that people have with these consumer products, with using ChatGPT on their phone or something else along those lines, in the clinical work that they do day in and day out as it continues to advance. Now, we have many applications of it today, but it will continue to change and evolve at lightning speed. So if I'm a nurse and I'm getting ready to go into work, I probably use the Maps app on my phone to help me find the fastest path into work. I will clock in and have some level of indication about how much time I have left to work in a given pay period. It's tracking things about what my scheduled shifts are, et cetera. And there's AI in all of those practical applications as well. And then I get into my clinical practice on a daily basis, and I'm likely to log into my EHR and do some documentation or at least do some review in that EHR. Now, in Epic, as Dr. Gerhardt mentioned earlier in the previous panel, we are leveraging generative AI to pull together a summary so that I can get myself up to speed with the relevant and timely information that may contain things that would have been lost in the translation or the handoff from another nurse to me. So there's plenty of opportunities for me to think about AI from a consumer standpoint, and then as I come into work day in and day out, how am I going to leverage that technology? At Epic, we have 297 organizations that are live using AI technology today, generative AI technology today. Some of the commentary that I hear from nurses, I spend quite a bit of my time out in the field with our end users. In terms of the chart summary at the beginning of a shift, a comment that I recently collected from a nurse is that this is the best chart summary I have ever seen in 23 years in practice. If I am at another organization that has robots that are doing delivery of medications from a pharmacy up to a nursing unit, the comment that I collected from that nurse was, I watched the Jetsons while I was growing up, and it feels like that's real life now. So there's plenty of opportunities to, again, think about this, but it doesn't come without challenges. And I think when we are evaluating, is AI the right tool, and is the type of AI that we're looking at the right tool, it starts to also force us to ask a question around, do we have different types of practice patterns between different types of clinicians? Now, providers, so physicians and advanced practice providers, have long been utilizers of dictation technology. And so the transition for them from dictation to ambient listening has been a relatively straightforward and relatively seamless experience. We are looking for the same opportunity to have an impact on our nursing colleagues, but that translation hasn't necessarily gone as smoothly as one might expect. And what I mean by that is nurses are historically poor narrators of their care. Now, that doesn't mean that we can't ask them to narrate their care, but again, if I go back out into the field and have a conversation with nurses, one of the first things that they'll tell me is, well, I was never trained to narrate my care, except in my health assessment class when I had to narrate it one time. But on an ongoing basis, I'm not sure that I want to narrate my care because I already feel like I don't have enough time in my day. And if I narrate my care, my patients may have more questions for me, and that's going to take more time. Now, I would venture to say that more engaged and more educated patients should have better patient outcomes. But we still need somebody to be able to sit and have that conversation. And the idea that we're just going to solve it by completing a head-to-toe documentation using ambient, I don't think is the appropriate use of ambient documentation for nurses. Where I do think we have a significant opportunity is around care progression, care planning, discharge planning, and patient education. Those are all really salient conversations that are happening in a patient's room, and it's an excellent opportunity to think about how we can leverage new AI technologies to be able to support that work. So the third point that I'd like to make, and then I'll turn it back over to Laura to open us up for any questions, is that while many of us in this room may consider ourselves experts in some domain of AI today, many of our colleagues at health systems across the country and around the world do not. They do not have a foundational understanding of all things that go into artificial intelligence. And we are asking them to lead the implementation of AI solutions to their workforce, and they may not have a full understanding of what it is that they are trying to get buy-in for. And so I think it's as a market supplier, it really kind of has forced us to think about trying to solve three key areas of, I would call it an education gap or a knowledge gap across the industry. The first is with health system leaders. We can do that as individual market suppliers on a particular part of technology. We likely can't do it for everything, but it's a good place for us to start and build that collaboration. The second is in tighter collaboration with schools of nursing to train the pipeline of future workforce development around what AI is. We don't necessarily need them to be total experts in large language models and how they work. That's not what we need to do, but we do need to have them understand have some foundational understanding of what is technology and what is AI in my clinical practice. And then the third, I think, is really a multimodal approach to addressing the 4.3 million registered nurses that we have who are in their clinical practice today. Those registered nurses will not step foot in a school of nursing unless they're going back to continue their education. But most of them will not go back through a baccalaureate or an associate's degree program. And so we have missed the opportunity in their pipeline development, and we need to think about an approach to getting back in front of all of the nurses who are in clinical practice today. That may look like TikTok for as long as it's around, education about what AI is on TikTok, social media platforms, whatever that looks like. I think we need to be thinking as an industry about how we're getting back in front of all of those end users. So, thank you.
Wow. I got that. Is it on? Can you hear? Great. Okay, perfect. Hard to hear up here a little bit. It's exactly what I expected from this panel, very provocative. And I think I'd like to dive a little bit further into, we've heard some mixed messages, I think, over the course of, I know the conferences that I go to and presentations that I see, I often see, particularly the ambient listening vendors will put up something that says, these are quotes from users, and they always say, best thing that ever happened to me, I'm enjoying clinical practice again. And I thought, well, grain of salt, until I went out to Appalachian Regional Health, until I went out to all those different places, and I heard it from the providers themselves, where they said, this is bar none the best thing. So we do see places where we're seeing acceptance like that. We're also seeing, I think, several of the labor contracts, again, incorporated things about sort of putting a stiff arm up against AI. So it is a bit of a mixed message in the workforce and feeling like they want to adopt this. What are you seeing? What are you learning? Are you researching anything about the actual resistance to? What are the barriers to adopting AI? We heard there from Dr. Ferris, the financial barrier. If it's going to impact your ability to bill for something, I can imagine you're probably going to be a little bit resistant. What are you seeing, hearing, and learning from that topic?
It's a great question. It's a great question, Laura. I definitely think when I go out to the bedside workforce, so if I go all the way to the person who is putting their hands on a patient every single day. Technology is not going to replace that interaction, but those are the clinicians who are maybe, or the consumers of AI who are least comfortable explaining what AI is doing in their clinical practice. They're least comfortable explaining it to their patients about how it is impacting their clinical practice or impacting their outcomes. And so one of the things that we continue to look at as an industry partner and at Epic, our nurse wellbeing team is focused on trying to have education about these tools that is getting to many different audiences, right? We can educate a chief nursing officer or a chief nursing informatics officer, or we can educate all of the nurse managers. But the final mile of getting adoption really happens at the bedside when there are peers of theirs who they feel that they can trust and are giving them insight into what it's doing. And so I think from our standpoint, we continue to look at the impact that AI is having, but then need to measure upstream about how the education that we're doing and the governance that exists, the transparency, as Dr. Longhurst talked about, around what the tools are actually doing are having in terms of an impact on the outcome and the utilization. It's a little like we can build the field of dreams, but we're going to spend a lot of money getting it there. And unless we give them confidence about its work and how it's going to impact the consistency with which it's going to have an impact in their clinical practice, I think that we run a risk of them not continuing to adopt.
It reminds me of the key principles of diffusion of innovation, Everett Rogers' work. There's a few things about the innovation, if you can describe it in those terms, and one of them is a clear relative advantage, and then the idea of who are the early adopters that the rest of the system follows. The tipping point is actually about 20% of those early adopters. You don't need to convince everyone, and that feels to me like what you're describing there, and it also sounds to me like a call to action for change management, where we really need to begin to understand what are the barriers, and they won't be monolithic. They'll be different for this particular group and that particular group with this geographic location or that one. So it sounds to me like some real attention to change management, at least as intensive as we had when we put in electronic health records.
Yeah.
I'll add to that as well. Getting trust. Trust is so important. And we've seen our healthcare industry really changing over the last decade, and the consolidation of healthcare systems, vertical integrations of physicians and healthcare workers. And theoretically, you can have economy of scale, and you can have a greater sense of agency and autonomy within an organization like that, because you can access expensive technologies and things like this that you couldn't otherwise have alone. But it does really require trust and partnership, value alignment, and a mission-centered approach to have that kind of trust, to get the buy-in. Seeking input, getting buy-in, I think is critical. And then showing that it's working in service to that mission.
Couldn't agree more. It really makes me think of the value of that second code commitment that we have around engaging those with agency, to be able to have them be able to affect the decisions, and people support what they help create. And I think that we've forgotten that so many times, that people support what they help create, what they feel like they've had a hand in shaping. And when they get their smell on it, so to speak, it becomes so much easier to adopt because they have had an ability. And I would say that we would have fewer rough spots in the road if we genuinely listen and incorporate that input. I'd like to turn it to audience questions now. Yeah.
Thank you. My question is for Mr. Springen. Let me put some context to my question, because I want to have you not feel like I'm jumping on you. So we're all familiar with the differences in using Android phones versus Apple phones versus Google phones, et cetera. So you might understand where I'm going to in this question. So have you and other EHRs like Cerner, eClinicalWorks, or Athena Health, have you all gotten together to kind of address some of the problems that have been plaguing EHRs, like interoperability and interfunctionality? And I understand business models are business models. However, but we as a healthcare community, we have suffered from problems with interoperability and interfunctionality. And I know the feds have tried to address that, but can you speak to something about that?
Absolutely, I'd be happy to. I'm actually going to address it in a couple of parts. So the first is, yes, I think interoperability has come a very long way in the last probably decade across the Epic community today. So with our client base, we know that they exchange upwards of 20 million patient records, and about half of those are to a system that does not use Epic. So there's a large percentage of interoperability that is happening already today. I do think that there's continued opportunity to make that as seamless as possible, to make it as actionable as possible, and to make it as complete as possible, right? All parts of a patient's record, social determinants of care, or social drivers of health, in addition to the medical care that's being provided at an individual organization. So I think that there is already some success that is happening today across vendor platforms to be able to do that. I will also say that there is a significant appetite and actually already significant action across vendors to come together to solve some of these issues. Yeah, so I was actually just at a meeting in Chicago last week where we had a smattering of other large industry suppliers, market suppliers that were together talking through some of these core issues. Interoperability, one of them, yes, but also around artificial intelligence, because at the end of the day, we all supply things to the United States, as well as many of us abroad. And so when we think about things like education of nurses or of other clinicians about AI or about a particular piece of technology, it's not something that plagues just us. It is something that we need to continue to educate more broadly on. I hope that answers some of your question.
Good.
Hey there, Steve Singer from ACCME. We're the continuing education accreditor. I love all this education talk, very exciting. You know, we keep, I have a sneaking suspicion that the more that we talk, the more questions we're going to have, right? This is such a enormous topic. It's sort of hard to constrain ourselves. One of the things that I'm thinking about, though, is that, you know, for good reason, our conversation is focused on AI tools, AI methods that will make these processes that you've been discussing hopefully better. I mean, that's really the question in the research. But as we talk about education, I'm thinking about Tate's now old research. It's not new research. The old research about that part of what drives well-being is not only things that we take out of the gas tank, like the burden of more emails and more all of these data interactions, et cetera, but also what we can put into the gas tank in terms of shared leadership, learning together, sharing the burden and meaning and opportunity of practicing and leading, et cetera, together. What about using AI for those purposes? And I know that that's probably a left turn from what you've been talking about, but I'm sort of thinking, like, why are we limiting ourselves to think about AI just in the interventional mode in terms of technical processes?
Go ahead.
Okay, that's an exciting topic. I love that because one of the things that I would love to see is that we improve the therapeutic relationship between the physician and the patient by having things like decision trees and the facilitated time to explain and educate and have truly informed shared decision-making and informed consent. And I think that would be one of the things I'd like to see that would improve education and also our therapeutic alliance together and that partnership of what we're trying to accomplish. So there's that, and I also would like to see, we talk a lot about reducing variation and things being reliable, but I'd also like to look at also how much variation around the mean is necessary for it to be valid and personal, where there's a latitude of control and that as well. So I think there's a lot of space to be innovative and new and insert it in ways instead of also taking away, patience over paperwork, get rid of the stupid stuff, and the hassle factor that keeps rearing its head every couple decades, and strangling in red tape that the ACPs put out white papers periodically saying the same thing, we're strangling in red tape, but there's so much we can get to if we can decompress and clear up the space to be innovative.
just have 25 seconds left, and I just want to add another element to that is when I think of things like the ECHO project in New Mexico, so they don't have enough specialists and providers. So someone comes on and there's a whole network of people who are rendering care to people in these areas that are underserved by specialists. They offer their specialist expertise to them. By extension, they're able to broaden that expertise. I'm thinking of learning collaboratives that we're going to have for people that are under-resourced in organizations, the Mississippi Community Health Center, Rural Hospital in Nebraska, the Inner City Chicago Hospital doesn't have that kind of resources. I can envision a learning collaborative around AI like that, and in some ways driven by AI to assist in lightening the load that it takes to learn from all of that. But what a collaboration that would be is for us to begin to learn collectively. This is an all teach, all learn moment. I think that's what we're feeling about this is, no one is behind on all of this right now because we all don't know where it's going exactly. And so it's wonderful to be on kind of the cutting edge, the very beginning of something that I think is truly transformational. Please join me in, go ahead.
Sorry, just very last question. I really love that question, and I think it really touches on something that we're doing. So right now we're working with health systems across the country to build a national intervention library, and at some point I would love to see us use AI to really tackle the idea of precision intervention. So we have all of these units that we know what are the top leading indicators. What I would love us to work on is using AI to then recommend the interventions that we know that have an effect size for the particular risk factors that we are looking at. So that kind of customized intervention, but really enabled by an AI and data-driven sort of power.
Please join me in welcoming this terrific panel. Appreciate it. In thanking the panel.
All right, let me ask my co-panelists, the ones who are in the room, to come up, and then also I know we have Mickey on the line virtually. All right. Good afternoon, everybody. I'm Elisa Ares-Bacochaga. There will not be a quiz on how to spell that. I am with the American Hospital Association, and I'm really, really pleased to have the ability to ask questions of this panel. This one really focuses on how do we navigate both the promise of all the things we've been talking about, and I really love the idea of I've just actually purchased for my husband those headphones because he has hearing aids, and so I will let you know how it works as soon as they get delivered. But I want to talk a little bit about how do we marry the human, because in the end we're people taking care of people, and you will never convince me that we will be able to do that without the people, and the technology, because the technology is fantastic. And I want to share just a really quick personal story. I was here in San Diego 2 years ago at a conference, and my husband rented a bike and went out for a bike ride, and he was supposed to be back and wasn't back, and we have set on our phones, where is his iPhone? And it pinged at UCSD Medical Center, which was nowhere on his route. So I called his phone, nobody answered. I jumped in a cab, I went up there, and on the way, because of the relationships we have as the American Hospital Association, I got Chris's cell phone number, and on a Sunday afternoon, I very boldly texted him and said, I don't know what's going on. I can't find my husband. I know his phone is in your building. Add to the story, he did not have ID on him, so he was, I think, Imagine 44 was his trauma name. So within probably 5 minutes of my conversation with Chris, their amazing trauma charge nurse, Dolores, was not only holding my hand and telling me what had happened, she had me at his bedside. And that piece, no AI is ever going to do. So I just want to set the stage for this session on How do we marry that? There's so much promise. We're going to talk about how do we navigate the potential while ensuring we don't add burden to our clinicians, we don't make them less able to do what they are there to do, and we don't use AI as a solution looking for a problem, right? We need to use it as effectively as we can. So each of our panelists is going to take about 5 minutes to just do some opening remarks, and then I have some questions, and I do absolutely welcome your questions, but I think the order we've got you is the way you're seated. So Tina, I'm going to turn it over to you and then take some notes.
All right, now I'm going to try and go under 5 minutes for a change. Let's see if we can do it. So my name is Tina Shah, and I'm a practicing pulmonary and critical care doc. I practice at the RWJ system in New Jersey, and I'm currently the chief clinical officer of a generative AI company called Abridge. I think it's also important to just kind of also mention that I've had a few tours in the federal government, and most recently in 22, I was the senior advisor to the U.S. Surgeon General. At that time, the Surgeon General wanted to plant the flag on clinician well-being, and some of us were able to hear some remarks from him today. He's actually been a co-chair of the NAMS Clinician Wellbeing Collaborative, so really kind of aligned and was really in the mix at that time. Have also been privileged to be one of the members, and I think the collaborative is on year 8. So sort of like taking a holistic view as to what has happened when we're now thinking about digital transformation and particularly AI. So if I were to take a step back, I think here are some facts. We think that burnout is largely a workplace issue. We know that there are evidence-based treatments, and we actually know that they work. But we also know that one of the lagging indicators is who's leaving the workforce. And if we just look at physicians alone, 2 out of 5 physicians intend to leave the workforce in the next 2 years. So we have this discrepancy in that we actually have evidence-based treatments, but why aren't they actually helping us solve our problem? And I think a big piece of that is the change management that's required. So on one hand, the evidence-based treatments work, but when we actually go out of the testing environment and we try and scale, are they really clinically significant? When I'm practicing, will I actually feel this in my health system despite the multi-pronged, very well laid out approach that my hospital system has? And so that's kind of like the opportunity or the gap, depending on how we want to think about it, as we start to come into this era where there are some folks in this room that are completely leaning into AI, and we'll hear about that soon. And then there are some other folks in this room that are in organizations that are wondering exactly how do I talk about this when I don't know. And I think some of the folks on our last panel were kind of highlighting the wide diversity and understanding of this topic. So here we now come in with something that's a little bit different. And I will say I've been working on burnout for over 10 years, and I found myself into tech. Not that I started out in tech trying to solve for a solution for burnout. And here's one of the things that really got me. I've never seen an intervention have such a quick turnaround and impact time, and also be something that had very, very low change management. And that's why I think we're at a very different scenario. So for all of us that have been, I think, drinking the well-being Kool-Aid and really understand this world of what do we do to take things off a clinician's plate, but then also put things on to create joy, there's something happening with the advent of this era of technology with AI that is about very short turnaround time. In fact, you can feel a difference within a week of use of some of these tools. I'm namely talking about ambient AI, but that is not the only one. What intervention is giving you an impact in a week or an impact in 30 days? So that's something that's kind of interesting. And also, what intervention feels like, air conditioning, in that you don't really have to actively do anything about it, but when it's off, you definitely feel it. So I know I'm talking about technology, and technology usually doesn't feel that user-friendly, but that is the expectation we should be having when we think about tools coming from the realm of generative AI, because it's actually happening present day in 2024. And to just put a little more meat to what I am saying, here are some hard facts, and this is coming from my company, which is one of the ambient AI vendors. The product we have is an app. Sometimes it's embedded in Epic, and I think Jackie had discussed some of this in her panel, where once you get consent from the patient, you have a recording and a listening in of that beautiful conversation between clinician, patient, and caregiver. And then within a minute, there is a complete summarization and drafting of your SOAP note, and also one written in regular language for a patient. And also there will be more things going from conversation to pre-templating orders, to coding and billing, to even serving up care gaps that we may have missed because we're moving too fast. But present day, in 30 days, we are noticing some pretty interesting things. A demonstrable effect on reducing burnout within 30 days. And Christine Olson, if you heard her on, I think it was 2 panels or last panel, was able to kind of describe in this multi-center study that it's not just a trend, it's a statistically significant reduction in burnout in 30 days. I think that's pretty insane. I'm going to share a study that one of the other authors is in the room, but it's going through review. It was a randomized trial where there was a half day of use of Abridge and ambient solution and a half day of not using this and doing standard of care with voice dictation, with dot phrases, all the tools we have. And it was a 61% reduction in cognitive load using the NASA Task Load Index. So we're really seeing some very, very hard, concrete changes. And I am going to be that person that talks a little bit about quotes, but hopefully, kind of giving a bit of a personal experience as a user, and then something I found kind of mind-blowing to sort of close us out, which is when I go in the hospital and I'm using Abridge, I'm rounding in the ICU. I plan on getting interrupted about 3 to 5 times per patient. If no one codes on me during rounds, it's like a victory day. And instead of going from 8 p.m. to 10 p.m. to co-sign notes, because the team is working so hard that our APPs and our residents just don't have time to do this documentation during the day, I'm spending half an hour. So I'm actually sleeping when I'm on service more than I was before. And I also have this instant memory where when we're doing afternoon rounds, I can see, did we actually address the top 3 issues or not? So there's all this stuff about time efficiency, and then there's all this stuff about, I have a second brain and it's actually way better than my first brain, and I like that, and I think that's pretty cool. But I'll kind of close with this, and I know we're gonna talk about consequences. Don't forget, right now I think a lot of the use cases require human in the loop. We're going after using AI for scenarios where we're doing something very, very often, like writing notes or responding to patient messages, but also the stakes are low. It's not clinical decision support right now. One of the talks that I listened to was from a CMIO, Sarah Rush, who's actually at Akron Children's. And she told me that when people are using Ambient at her institution, the pediatricians are actually addressing problems that they never would have touched before. That upstream stuff that we're supposed to do for preventative care, it's because it would take forever to document all of that. And now they actually have time. So they're talking to the kids and to their parents about these really tough topics that hopefully will avert the need for some of the sequelae that are to come. And I think that's kind of interesting as far as really leveling up quality of care.
Wonderful. Thank you for sharing. Dr. Singh?
Is it on?
Yep.
Okay. Hi, everyone. My name is Karandeep Singh. I'm the Chief Health AI Officer at UC San Diego Health, also an Associate Professor in the Division of Biomedical Informatics. Prior to coming to UC San Diego, I had started our Health AI governance at the University of Michigan. And so I actually am not an AI evangelist. I'm very much an AI realist. And so I have to remind people that despite the fact that AI is in my title, I'm not here to push AI. I'm here to figure out, like, is it really the right thing? And what do we need to do to figure out if we can use it safely and effectively? So I think the questions I wanted to touch on were really 3 things. One is generative AI risky? Like, is it risky? What are the actual transformational opportunities for well-being in generative AI? And then, will augmented intelligence help fix burnout? So those are 3 things I'll try to touch on. So I think to understand if generative AI is risky, we have to look at what systems have we put in place to govern health AI in the predictive AI space, which has been around for a lot longer, even predating machine learning. And if you look at predictive AI, many of the tools that we're using at a patient-level scale, not necessarily at a system scale. And the risks largely come from the fact that we use a predictive AI tool, someone has higher risk. we use that risk score to reallocate care. And either that reallocation of care is something that's reallocating a care that we don't want to, like it's doing it in an inequitable way or in a way that we disagree with, or it's creating additional work burden through a workflow that we've latched onto the AI that is now causing people to have to go do something, whereas before they wouldn't have had to. So a classic example, like in sepsis and deterioration, is that previously, a rapid response team might have been sitting there waiting for the next rapid response. But if the team wants to proactively round using these tools or get alerts, now they're going to stop what they're doing, go check in on patients, and so that you hope that those tools are good enough where they're actually kind of worth it to interrupt workflow. And in a lot of ways, those are tools that aren't intended to reduce burnout, they're intended to improve patient safety. We've discovered lots of things along the way, like things that work in one place don't work in another. And so it's not surprising that we have things published where some center says, hey, this doesn't work. Some center says this is the best thing ever. And so I think recognizing that that happens, a lot of places have realized you need local governance for these tools, and you need local ways of looking at them and measuring them and figuring out if they work. So I think many organizations, alluding to what Laura, you were talking about, have a set of principles of like, these are the principles we want. Like, we want the AI to be fair, we want it to be effective, and so on. How do you figure out if generative AI is fair? How do you figure out if generative AI is effective? This is something that I think a lot of health systems on their governance thing, on their governance groups are really grappling with right now. Like, what does that actually mean? And it is true that the kind of errors that are seen in generative AI are very recognizable, but they're a little bit difficult to characterize. Like, for example, we know that there are errors of omission where something gets left out of a summary. There are errors of commission, right, which are effectively hallucinations. And we know that both of those are problematic, but it's hard to know, for a given hallucination, like, is that really, really bad? Is that a showstopper, or is that okay? We know that biased language can be introduced, and going back to, I think, Dr. Timothy Ferris's point, right? Existing notes already have bias that's been published about, and so the fact that generative AI generated notes might have bias is not like a big shocker, and potentially not reason in and of itself not to use it. But the bigger challenge is it's actually harder to measure the risks. Like with predictive AI, there's a lot of metrics you can measure and be pretty confident that you have a relative understanding of false positive rates and false negative rates at given thresholds and say, yeah, that actually doesn't pass the sniff test. With generative AI, even outside of healthcare, the best tools that we have to do benchmarking are tools like Chatbot Arena, where you have a bunch of humans looking at tools, comparing them side by side and saying, yeah, that one looks better, that one looks better. It's essentially like an optometry test with your eyes, but for LLMs. So I think, even from that, there's been a lot of innovation. Now you can use large language models to be the judge and figure out whether other large language models are better than, these language models. And so the point being, I think that it's really hard to know as an AI governance group, how much weight do you put into needing to do full red teaming of these tools or not? And really, what is the real risk? Because the risk for one error of commission might be very different than the risk for some other error of commission. So where are the risks higher? I would say risks are higher for clinical use cases, right? So even without automation, open-ended question answering is something that people view as a risk. So if you look at many of the institution's prompts that use automated in-basket reply, where it's a drafts reply that clinicians can edit, many of them will say, don't give medical advice, don't add clinical things here. We don't want to color the clinician's thinking with kind of AI-generated advice. And yet, what happens as a result of that is that we tell our prompts, don't give medical advice, don't tell patients anything that could be medically useful, don't say anything around referrals, don't offer appointments, don't offer follow-up. And so essentially, what you're working towards is a reply that says, hello, it's nice to meet you. And so I think the key thing here is that we can have those principles. We don't necessarily want to encode those principles purely in our prompts, because it's not going to be very helpful from a well-being standpoint if you as a clinician have to add everything there as boilerplate, because all the real information stuff that was medically useful to the patient actually got pulled out. I think the other really high-risk areas are, when we think from a governance standpoint, is direct to patients. And I think direct to patients could be chatbots. Historically, chatbots have been very decision tree oriented. And when you introduce an LLM, I agree that they often lose a little bit of that decision tree. And the issue is that it can go off script. And so as long as they are possibly able to go off script with a patient who is asking questions in a specific way, I think there's a real question of that's an uncertainty you don't have to deal with in predictive AI, that you have to figure out how do you deal with in the space of generative AI. And obviously there are situations where the law applies. Like medical translation, when accuracy is important, you cannot use automated translation. And yet we have to look at where are the transformational opportunities. And I would say on the patient side, it's all the things that patients are already doing. Direct to patient is something that we may not feel comfortable doing. Patients are doing it. So when they go see an appointment, they're using it at home. I use it for family members. We'll look stuff up there just to see like, okay, what do we need to talk about today? What are questions you should be asking? And that's the sort of prep stuff that I think a lot of patients actually do, even ones who aren't that technically savvy. And so I think we have to get comfortable with the idea that patients are doing it. And if we can encourage it or we can figure out how they do it safely, like what does it look like to interface in a way that gives you something that that is more reliable than how you might do it, completely not knowing anything about large language models, that may be a way to now get into a transformational opportunity to reduce burnout. Similarly, medical translation, I think I don't have a strong opinion on this because I understand the issues on both sides of trying to automate translation. But I, for the first time when I was at CVS, saw a sign that had something translated into Punjabi. I have never in my life seen any one of those hello signs where they say hello in all the different languages ever say anything in Punjabi. And usually when they do, it's like they've just taken the Hindi word and turned it into Punjabi letters. And I'm like, that's great, but that's not actually even what Google Translate would tell you. So I think augmented intelligence is something that we as clinicians often fall back on as a safety net. We say augmented intelligence is AI helping clinicians do things the way they're already doing them. And I would say that only works if it actually improves well-being and saves costs. And my worry is that that approach will ultimately end up just costing more money without seeing some of the benefits that we want to see. So an example being with ambient, if you look at the published literature, there's a couple of papers out there, and one of them shows we save time after 7 p.m. So great, where are you going to add that additional patient for the time saving that happens after 7 p.m.? At 7 p.m.? So I think there's a real recognition there that it may not actually save time in a place where you have an ability to get increased productivity, and you have to either be okay with that or figure out a financial model where that still makes sense to do from a well-being perspective. And I think the other paper that came out in this showed that I think the savings were largely in family medicine. And so as we think about how we roll these things out, I think we have to figure out what is our strategy for rollout that actually makes the technology potentially pay for itself, focusing on the areas where there's maybe the highest efficacy. And so I think this is something that I think is important for us to think about. And so I would submit to you that it is risky. There are some risks. The risks are hard to measure, which is what makes it difficult for us to move forward. But I still would submit that if we want to see real transformational improvements, we can't just latch AI onto the way we do things, but we have to think about new opportunities to increase access to care to people who are already using AI today in responsible ways, rather than really kind of treating it as like you have to come to us and we are the arbiters of care, because that model, there's not enough clinicians out there to actually meet the needs of the population today.
Well, thank you, Dr. Singh. I think there's certainly a lot of opportunity there. And as someone who's had to, for family, translate medical language into Spanish, which it turns out I speak fluently, but have zero ability to speak doctor, it's really way harder than you think. Dr. Tripathi, let me turn to you.
Okay, hello, can you hear me okay?
We can hear you great, thank you.
I guess a couple of thoughts that have sort of struck me as we're thinking about this question of burnout, user adoption, and technology. And it reflects a little bit of the experiences that we've had with electronic health records, and some of those may be worth thinking about as we think about this next generation of technology. I kind of put it into two categories. One is governance, and the other is implementation, because I think both of those directly affect this idea of clinician burnout. all too often, it's not the technology, it's actually how we implement the technology and how we select which technologies we're going to use and how we implement the technologies that I think are at issue. Reflecting back on our, now, fairly extensive experience with electronic health records, we've seen that to the extent that, if you go back to when we were first implementing electronic health records at scale as a part of the federal incentive program, there was, we're all climbing the Gartner hype curve, and getting up to the top of the peak of our expectations. And everyone had the sense that this is actually going to reduce burden. This is actually going to take away so much rote work. Physicians will be on the beach doing their notes, and it'll be awesome. And of course, the reality is that the electronic health record became the vehicle for piling on a whole bunch of other stuff. That wasn't necessarily a part of the electronic health record, but certainly had dramatic impacts on clinician workload and the sense of burnout that providers have every single day. So I think that's sort of one of the challenges for us is just the recognition these are just technologies that exist within a system that is increasingly about incentives that are financial and economic, and aren't really about addressing specifically issues related to the health and well-being of providers, and we might even argue the health and well-being of patients, directly. So I think that's one important piece of context that that we all just need to keep in mind. And and one overarching concern with that I have, for example, is how do these technologies just get weaponized in the for the same things that are being weaponized today? So we have an expectation and a hope that these technologies will be great for reducing the burden of prior auth, for example, as one huge physician pain point that we've identified at ONC and a lot of work that we've done with CMS on burnout. And of course, that assumes that everyone else is standing still, which they're not. There's evidence that we know of the rising arms race between payers and providers and the uses of these technologies, and all we have is the robots fighting against each other. That gets us higher and higher to the same, and we end up in the same place as before. And clinicians don't feel any less burdened than perhaps they do today. So I think that's an ongoing challenge that we're going to have to be attentive to if we want to be able to, at the end of this, say that this is actually made for a net reduction in the factors that contribute to clinician burnout. And the other element of this is the issues of productivity. Whenever I hear and people talk about, well, this is going to shave 2 minutes off of every visit. Every clinician I know is thinking in their heads, that means that someone is going to try to pile 2 more patients onto my schedule. They're not thinking that, oh, I'm going to get more time per patient, or I'm going to get to go home early for a change. So I think we just have to keep in mind that this is really within a business climate that itself needs to focus specifically on issues related to burnout, and the technology is not going to be a magic bullet that solves that. As we think about the key things that I think can be factors in helping to give greater confidence that these technologies can be used in ways that help to address some of these concerns. One is related to governance, and what I mean by governance, when I speak of governance, I mean local governance, which is about provider organizations, whether it's the enterprise or a physician office, being thoughtful about how they're thinking about the adoption of this next generation of technologies, where it makes sense for them and where it may not make sense for them. And and I would argue it is a perfectly legitimate strategy to say that I'm going to wait and I'll let the Mayo Clinics of the world be the vanguard of this, and I'll wait until the dust is settled on some of these technologies. We have a better sense of how they get used day to day and where the benefits will be for us in our particular setting before adopting them. Because that otherwise they just get imposed on people. So I think that's one key element, and certainly related to some of the issues that Karandeep was talking about related to trust, which I think is an important part as well. I mean, there's nothing that will contribute to more anxiety, which will contribute to more burnout, is if people are being forced to use technologies that they inherently don't trust, but they feel that they are, having some, there's some kind of organizational compulsion for them to use them in ways that they're uncomfortable with. I think the second element is, sort of segue to that, is about training. My mother, this is not an AI story, but I think it's a useful example. My mother, about a year and a half ago, broke her hip, and we were transferring her. She's fine. She had her surgery in an acute care hospital in Massachusetts, and we were transferring her to a rehab hospital just down the road, less than a mile down the road. They exchange 10 gazillion patients every week, so long-standing relationships. Both of them are on top electronic health record systems that I know for a fact are connected on the back end through one of the nationwide networks. So they can absolutely exchange information electronically. Yet, when we were discharging my mother and going to bring her to the rehab hospital, all of you can imagine what happened. They printed out a big stack of notes. My mother's 90 years old. They printed out a big stack of records, handed them to us, and asked us to bring them to the next point of care so that those could be scanned in a page at a time into that next system. And that was despite the fact that they've got all the interoperability they need on the back end, but the front end staff had not been trained, had not been made aware of those electronic systems. So they were still facing that paper burden of having to do this every single time, which they hated. And I described to them the electronic system that existed in their system today. And the comment I got back from them was, I can't wait till we have that. That's going to be truly awesome. So I would just point out that the same thing can happen with AI-based technologies, right? That they just get dumped on the frontline staff and the frontline users, and that will just add to a sense of burden and to clinician burden, unless they're really thoughtfully governed in terms of what's going to be made available, and thoughtfully executed and implemented in terms of training and expectation setting.
Thank you so much. Having also experienced we can read all the notes, but we can't see any of the imaging from the work you had done over here. I'm always amazed at the amazing connection we have and then the lack of connection. Let me ask of each of our panelists a little bit about how you're seeing technology or the ability of technology to maybe unsilo some of the well-being. I was talking earlier with some of our colleagues here about the challenge that we face in well-being being viewed as separate from quality, from patient safety, from how we bill. All of these things are interconnected. I think all three of you referenced the idea of if we can make things better for the clinician, maybe we can add a couple more patients, right? Like that's not going to make things better for clinicians. So how do you see these technologies maybe unsiloing well-being and being something that helps everyone see the broader picture of how do we maintain a workforce to provide good care to our patients?
I guess I can try and go first. Just conceive of us being at a pivotal moment where this isn't like, oh, there's this thing AI, and if you're not IT forward, it feels kind of funny, and you're like, maybe I'll wait for my colleagues to kind of sort this out where I work. But imagine if we use this moment as the secret weapon to break the silos. So it's so jazzy right now, and there are a million articles being published about AI in every industry, including ours, that could I, wearing a CWO hat, now be able to carry out the well-being agenda, although I'm sitting at the table with the chief information officer? Or could I, the chief medical officer, carry out my secret agenda, seeing what's happening on the med-mal side with disruptive physicians and tracing that all the way back to, operational decisions that we made that then lead people to, to become exasperated. Can I enact a secret agenda because everyone's so excited and so curious, and the playing field has been a little bit leveled because AI is new-ish for many that are decision makers? I think that's the promise, and maybe I'm being overly optimistic, but I'm just going to close with one thing, and I'm so curious what you have to say, Karandeep, and what you have to say, Mickey, but I think we have a third of the right people at the table right now when it comes to governance in health systems with how we're using AI. Notably absent still feels like the well-being experts, and without that, we run a very high risk of doing something where we hurt the very people we're trying to help.
Karandeep or Mickey?
Yeah, so I'm not a well-being expert. And so I think In general, though, I think being able to measure something is the first step to being able to fix it. And so I think there was a point made earlier that technology doesn't solve problems, people solve problems. And so I would just say a lot of what I'm doing in my role now is looking at what are some of the pain points we have where we do a lot of time reviewing charts. And while ambient is one of those, there are many, many, many others across kind of measuring quality, measuring safety, where we have people who are clinicians, maybe not in clinical roles, but sitting and reading charts. And a lot of those kinds of jobs also have kind of opportunities for well-being, whether clinical or non-clinical, by having automated summaries, some level of suggested boilerplate text to support things like the task automation that Jackie was referring to. So I think that there are a lot of these opportunities. So largely it comes down to, I think we have a larger arsenal of tools. Like before, if someone said, oh, I need just to extract this one little measure out of this kind of a report, I would have said that's a solution where you have to use regular expressions, and you need to tell me all the different ways you might say that phrase so I can kind of write the code to do that. And today, that's like something I can do in an evening, just on the side and say, what was the issue? Okay, tomorrow I'll have a prototype for you. So I think that's the kind of world we're in, but we have to be able to capitalize on that. And so I think it's still largely a pain point oriented thing.
Mickey.
Yeah, I could see that, this question of well-being, one of the deeper and, hopes that I have is that bringing greater agency to patients will help to bring greater agency to providers. And that will allow clinicians to get back to practicing the way that they wanted to practice, which is in a more engaged manner with patients, and being able to focus their time not on trying to figure out where all this assemblage of data is and rapidly trying to synthesize it and knowing that there are real holes there, but the ability of AI-based systems to be able to get more signal from noise. We think about all the narratives and everything that's buried in the EHR system, as well as all the other ancillary systems in a complex hospital, for example, being able to synthesize and summarize that, and actually being able to have the patient have access to that information, which they are required by regulation now to have access to, but most of them don't find it very usable. But their ability to have tools that allow them to come to the table with a more informed perspective and to be able to, sort of more deeply engage with providers feels to me like something that could be very powerful. It doesn't happen overnight, and there's a lot of cultural change that happens there as well. But it feels like that, could be a real prospect for bringing healthcare back to life for a lot of people, no pun intended.
All right, let me open it up to the audience here. And if I did this correctly I can actually see questions on my phone that people are adding online. So if you are on the webcast, please feel free to add in questions online. But I see a couple, Nigel in the back, and then Laura.
More of a comment rather than a question. I did like Tina's points towards saying about, having, or maybe this happens in organizations, having well-being experts that can sort of having well-being experts at the governance table. At our organization, I've run into this kind of halo bias effect where patients first is one of our organizational values, and we call them rapid regs or regulatory bundles that we have to do every year. Where you have to do 21 modules on patient safety.
And it would take our physicians on average about 2.5 hours every year to do them. And whenever I challenge folks to say, well, do we have to do these all every year? The response would be, yes, we have to, because, we're a quality and safety organization, and, this is for our patients. And as it turns out, you don't have to do them, or you don't have to have tests at the end. You can have simple attestation. So I guess my point is, I often hear for years pushback on well-meaning or initiatives for physician well-being, because there's an over-concern about patient safety. And yeah, just sort of a rambling point about trying to introduce well-being experts more at the governance table. Thank you.
Thanks. Laura?
Quick question for you, Tina. I'm thinking about, as long as we're thinking about pushing the envelope and we're talking about continuous education, would a bridge ever think about broadening your scope to something like, some clinicians would really like to be more empathetic, but they don't know how. They're not given feedback. What if your clinical summary that you develop also gives them feedback on their empathy and what they might have done? Now, this is obviously not for everyone. A lot of people don't like feedback and don't want it, so it'd have to be sort of an optional thing, but there would be a continuous learning opportunity if it could feed back to your clinicians at the end of their day where there was an opportunity to be more empathetic. I just wondered if you've ever considered that, or does that look like the third rail?
Are you part of our Slack community? So it's definitely something we've been thinking about, but here's where I love, we're a clinician, we're a co-founded company, so our CEO is actually a practicing cardiologist. There's a definite tension. I mean, we can probably tick off a ton of clinicians if we do this wrong. If we give a lot of information, it's gonna feel like how patient experience, and remember when everything got Yelpified? And like I was receiving these reports of how my progress was, but then it also was like Google reviews and Yelp reviews and then whatever the hospital gave me. And I feel like there was a ton of backlash when that first started. So we're definitely taking a slow hand on this because I think there's a lot to be gleaned. I mean, we could serve up something immediately or in real time. We also could look at the tonality and think about the audio data we're getting and how to use that to even diagnose burnout, but also say, look, like, your tone definitely changed. This could also help with, some of the biased care we provide. I mean, the possibilities are limitless. I think here's where we really need the marrying of these amazing AI ML experts with clinicians so that we don't hurt clinicians in trying to give positive feedback.
All right, we have about 20 seconds left, so I am just going to sum up a couple of things that I wrote down because they were struck me. One, at what point does AI become the air conditioning in the room? When does it be the thing that is running in the background, but we only notice it when it's not working? And I really love the point of understanding the motivation of the people who are doing, who are making the decisions and how to get the right motivation around the table, and the importance of trust, because that is what you all as clinicians have with your patients, and that the AI doesn't necessarily have that because it hasn't earned it. So I thank my amazing panelists for sharing their thoughts, and I get the opportunity to invite you to take a 10-minute break and get up and stretch and go look at the beautiful ocean for those who are in the room. Thanks.
All right. Good afternoon. So I recognize that earlier today I stood between you and lunch, and today, again, I stand between you and the reception, so here we are. Again, my name is Margaret Lozavatsky, and I have the pleasure of moderating this fantastic panel. So I'm going to invite, I think we have all the panelists now, and we have one online. This is a very exciting topic for me because this is the part where we bring it all together and really talk about the vision of what the future looks like. And I wanted to share a couple thoughts on how we think about this space. As we've discussed today, there's a lot of potential with AI, and we're all here to focus on well-being, which is a topic near and dear to our hearts. And the questions that we're going to talk about here is, how do we make this successful? How do we bring these tools to our clinicians in a way that will actually address the issues with burden reduction? And we think about all of the experience we've had. A lot of folks today have alluded to digital technologies and EHRs. And one of the things that I have often reflected on is we have tried to bring some of these tools, particularly the digital health movement, sometimes in a little bit of a silo. We were very excited about the technologies, and we built up these teams within our organizations that would think about all of these technologies on their own. And so what would often happen is you had a lot of enthusiasm. I had a lot of clinicians and non-clinicians come to me and say, we are going to solve this problem. The example that always comes to mind is in endocrinology, when we take care of all of our diabetics, there's often not integration with their glucose measurements. Everybody's been trying to tackle this for years and years and years. And every time a team has come to me with a solution that they had in mind, the way that they described it is, here, you just open this window and you click here, and 20 steps later, look, we have a perfect solution for you. And the response is, that's all great, nobody's going to use it. And as I like to say, if you build it, they will not come. So how do we do this differently? How do we bring AI tools to our clinicians in a way where it is seamless and it is integrated into their process? I think it was Dr. Shah earlier today that mentioned that the reason she got into this was not because of the tech. It was because of the focus on well-being. And it made me think about the reason that I got into clinical informatics. And it was very much because of the needs of the clinicians. When I was taking care of patients, I recognized there are all these things that were not working well for me. And some of the simplest interventions, my very first project as a clinical informaticist was when I recognized, and I see Dr. Longhurst smiling over there because he probably knows what I'm going to mention. I recognized that one of the biggest challenges in pediatric hospitalist work is having to manage jaundice, of all things, because bilirubin measurements are based on the number of hours. So for every single baby that was born, I would have to figure out at that point in time how many hours they are. And when you're post-call and exhausted and you have 30 babies on your service and you're sitting there on your fingers saying 45 hours, 46 hours, it is exhausting. And I thought, man, computers should be able to solve this. And so we worked together with billytool.org, and we were able to put in a process into our electronic medical record where with one click, the clinician could not only get the guidance for what level of risk the baby had, but also next steps. And so we did a time study, and we were saving about 2.5 minutes per lab result per physician. And so we extrapolated that to all of our babies, and we were saving over 100 hours of physician time in a month. And I have never, to this day, implemented any tool where people were literally hugging me in the hallways saying, oh my gosh, I can't believe we didn't think of this earlier. We had 100% adoption. And about a year ago, so this was probably a decade ago, about a year ago, they reached out to tell me they still have 100% adoption. They're still monitoring this, and it is still the most loved tool in pediatrics. So I share this story with you to help us all think about how do we get to a place when we integrate AI into our clinical processes, and that's the response we get. Everyone's hugging us in the hallways. That's what we want to get to. And so with that, I'd love to introduce our panelists. I'm going to give them a minute or two to just give a quick introduction about their background, and then we're going to ask them some of these questions. How are we going to help bring well-being back to our clinicians, bring the joy of medicine back to the bedside?
Thank you. That was a wonderful story. My name is Divya Pathak. I'm the Chief Data and AI Officer at the New York City Health and Hospitals, the largest public healthcare delivery system in the country. And we serve over 1.4 New Yorkers, irrespective of the racial, legal, and social status. Prior to that, I was at Mayo Clinic. I was the Vice Chair for AI and Analytics in the Center for Digital Health, mainly working with clinicians to understand their real-world problems and looking at ways we could solve some of those challenges using AI and analytics. I'm going to hand it over to Dr. Toko.
Eric Topol. I'm at Scripps Research, work on biomedical AI, and anxious to get into the discussion.
And online. Oh, you're muted.
I'm sorry, can you hear me?
Yes.
Great. Hi, Sarah Rossetti. I'm an associate professor in the Department of Biomedical Informatics and the School of Nursing at Columbia University. And my research focuses around how we can better use the electronic health record, around clinical decision support and decreasing patient harms. I also focus a lot in my work on decreasing documentation burden. I chair AMIA's 25x5 task force focused on reducing documentation burden.
Fantastic. And since we were with Dr. Sarah Rossetti there, I'm going to start with you. Can you please share some of the challenges that nurses are experiencing today with clinical technology?
Great, thanks. So I thought I'd actually start with a brief example talking about nursing surveillance, which is a systematic process that includes pattern recognition, anticipating problems, coordinated communication, and decision-making to identify patient risk, escalate care, and prevent harm. So typical work that all hospital nurses perform every day, often without decision support, which is why the brief case I'll convey is not about the most complex ICU patient where innovations are often targeted. So for example, you log into the EHR after getting handoff and doing your initial assessments for the day. It's only 9:15 a.m. and you're bombarded with red flags about documentation that's overdue. All structured data you manually need to enter. Clicking through hundreds of fields, with much of that required data you enter being the same for all your patients and often not related to your primary concerns for your patients. But those red flags and structured data need to wait because you know it's not your real job or real professional responsibility. You're looking in the EHR to get a better sense of the patient in room 286, Mr. Flynn's baseline in past 24 hours. His blood pressure is 100/60, still within normal. So none of those EHR flags were for him, but you know it's not normal for him and he didn't look right. Usually he runs in the 120 to 130 range. You go back in the room, ask some more questions. He didn't want breakfast. He's a little confused. Well, for him, it's actually a lot confused. At handoff, the night nurse told you he was looking forward to doing the Sunday crossword this morning, like he does every week, but he can barely focus on it. You tell the resident, we need to round on Mr. Flynn very soon. You think he might be bleeding and the team should be aware. So it's been said that nursing surveillance is a complex process that defies empirical measurement in and of itself. But with AI, we can actually measure it and elevate it. But to do that, we need to use ambient AI to automate manual data entry for nurses, protect nurses' time, and then we can leverage LLMs to enhance clinical reasoning. So I lead the Concern Early Warning Score study with Ken Ricato, who presented earlier today. We ran a multi-site trial that found a decreased risk of mortality by 35.6%, decreased risk of sepsis by 7.5%, and over a half a day shorter length of stay because our early warning score has a 2-day earlier lead time than other early warning scores. So how? Our AI algorithm measures nursing surveillance in a very novel way through metadata, proxies of when a nurse is concerned about a patient. We don't use any physiological values in the model. We model nursing behavior, such as how frequently and at what uncommon times did the nurse document a variety of data points, such as an extra set of vital signs, giving PRN medications, and writing additional notes. So it's a proxy measure of nurses' concern by observing when the nurse changes their care patterns in response to a patient's subtle changing condition. Amazingly, these are all optional data points above and beyond documentation requirements. So I just want to pause and emphasize that point. This incredible data signals arguably a very large impact on patient outcome is occurring separately from the documentation requirements we impose on nurses. Too often, any time saved through efficiency projects is filled by hospital leaders with more tasks, more documentation, and heavier workloads for nursing. But done right, AI can transform what was previously mistaken as nurses' downtime, their time to think, time to synthesize, time to plan, as the time we actually need to protect. Our vision for AI needs laser focus on the actual clinical work that impacts patients, but is sometimes invisible to non-clinicians. So if 5 years from now, we still have nurses manually entering thousands of structured data fields, and flow sheets do have thousands of data fields in them, but LLMs are generating notes using data manually entered by nurses, we have done something wrong. There may be one silver lining to the fact that nurses still have not been able to bill for the care they deliver. Their documentation fields and structures can change. So clinical documentation is viewable, and it's a log task, and we can currently measure it. Thinking, discussing, gathering, planning, and reaching shared team situational awareness about a patient's needs. These are critical clinical activities, but they're less valued. Because while there's literature about their importance, they're not allocated sufficient time and are not practically part of the measurable and billable world of healthcare. It's important to emphasize that my remarks are specific to nurses, but all clinicians suffer from excessive task burden. And I know it has been discussed today, and we need to look at AI solutions that elevate all clinicians practicing at the top of their license. AI can change for nursing if design of innovations are nurse-led to re-envision socio-technical environments and how we expect nurses to engage with that environment. First, ambient AI solutions are going to be the most critical for inpatient nursing to get rid of the volumes of manual structured data entry once and for all. This also includes AI solutions that don't involve the nurse for burdensome requirements that never should have been put on nursing in the first place. For those that worry about data quality and workflows with ambient AI, there are hurdles to overcome. But let's remember our current EHRs have low data quality right now. Today, poor EHR configurations force nurses to enter known erroneous data because they simply need to get back to patient care. We need to move forward. Ambient AI solutions at the first stages of development need to consider all the messiness of nursing data and patient data and not set aside the messiness as edge cases. So this includes how nurses move room to room, having multiple patients per room, accounting for sensitive data, adding context such as a normal blood pressure that's not actually normal for that patient, or highlighting things such as why it matters that a family member is at the airport and should get there by this afternoon. Lifting the burden of manual data entry will open vast opportunities for insights into patient data by nurses, as long as we protect their time and engage them in development. Now, we do have to be careful that vigilance for LLM data quality doesn't default to nursing, as historically those types of tasks have. But LLMs that are team and patient-centered offer potential to elevate clinical reasoning, nursing surveillance, care planning, coordination by illuminating clinical relationships beyond linear associations in the sea of noisy data that we have. Remember, our concern model doesn't use clinical or physiological data. Rather, by modeling nurse behavior and how the nurse modifies care to fit changing patient conditions, we're able to predict sepsis transfer to the ICU and death 2 days earlier than using vital signs in labs. So imagine what an LLM powered with ambient AI that captures nurses' clinical reasoning and surveillance activities, not just tasks, can do. That, to me, would really be patient-tailored care. Right now, nurses at hospitals throughout our country are breaking their backs to find time for clinical reasoning and surveillance activities amidst a sea of data entry tasks and information overload. So I'm excited for and looking forward to a new patient-centered AI socio-technical environment where clinical reasoning, surveillance, decision-making, and care planning are prioritized as central processes that the entire care team engages in, supported by AI tools that capture data, surface key linkages, and synthesize information.
Thank you. That's fantastic. We really appreciate the vision of We really appreciate your vision of what AI can do to support nursing. We're going to switch gears and talk a little bit about operations. And so I'm going to ask Divya the same question. What do you think are some of the successes that you've seen with AI use in healthcare today to support operations? And what is your vision for how it can support operations in the future?
Thank you, Margaret. That's my sweet spot. I'll take a different angle than what Dr. Rossetti was talking about. If you look at any of the challenges when it comes to AI implementations in healthcare, I'm going to speak about some of the success use cases, especially when it comes to integration, addressing some of the problems. So one big example I would give is over the last 2 years in New York City, there's been an influx of patient volume. So we have over 50,000 newly added patients in primary care settings. which leads to average waiting times for over 50% for adults and over 40% for children. So that's real statistics. So we talk about increased patient volumes and we talk about clinical burnout. It's a perfect example of looking at how we can implement AI. So one of the areas that we have started exploring is to actually look at ambient listening technologies, not in just support of provider burnout and also in support of some of the provider retention and recruitment issues that we have been facing. So that's an area, and in doing that, there are ample studies talking about how ambient listening solutions leads to increased, reduces the cognitive burden, but we do see that that is not leading to increased productivity or increased financial metrics for organizations. So that's still, I would say, right, that's still an area to improve by health systems. In terms of well-being and burnout, we also need to bring into other healthcare workers into the equation, talking about quality and safety. We talk about chart abstractions either to support the CMS requirements, or we talk about chart abstractions just to support internal quality improvement initiatives. So that's a very, very humanly laborious, intensive process where we've started implementing generative AI to look at extraction of quality elements, supporting some of the ECQM extraction, but also in support of bundled extraction for quality reporting. The third area I would like to talk about is just our the denials and optimization. There's a lot of charges that's missed today, buried in our clinical notes, not coded rightly, and there's a difference between physician billing and hospital billing. You have a lot of redundant processes, and more importantly, there's a big workforce behind this in support of optimizing the denials. That's an area, again, we're talking about healthcare workforce. That's an area we really are implementing large language models in support of CPT4 and other codes extraction, so we could actually bill our payers appropriately. Those would be my examples, and these go not with no issues and integration challenges. Anytime you're bringing in AI, there's a multidisciplinary team involved from the start of the design to implementing and also involved in the change management processes. Change management requires workforce trust and adoption. That requires a lot of training. So heavy emphasis on training, more importantly, and also looking at having new workflows created with AI intervention has been a big focus.
Fantastic, thank you. I know we've had a lot of conversation today in this room about cognitive burden, and that is an interest of yours, Dr. Topol. Can you tell us a little bit about what clinicians are experiencing today and what you think the role of AI will be to help address some of the cognitive burden challenges?
Well, I don't know about the term cognitive burden, but there's just too much data, too much information, and it's not, any human could handle all that, so that's why we have to lean on machines. I think firstly, unfortunately I wasn't able to be here earlier, but we keep talking about on the clinician side, but there's a lot to foster for patients to give them more empowerment. And that also decompresses the work of clinicians so that they already have their data all organized. Part of the problem in this country is they don't have their data. They have modest access to portals, and it's incomplete, and it's not all together. And they can't even have it all in one place because if they have something like a genome, it can't be in their electronic record, and the sensor data is not pulled together. So that's a problem, but if we use AI there, I mean, we're already seeing many examples where patients can get a preliminary diagnosis of things, including diabetic retinopathy, skin lesions, ear infections in children, heart arrhythmias through a smartwatch. So that's an area that I don't think clinicians think about more, is why not give more power to patients? Why not they have their own data? And we're not really doing anything for that. As far as on the clinical side, I think that if we got rid of keyboards, liberate them from being attached to clinicians, that would be a great thing. We should be striving to do that. We can do that. The ability to not be a data clerk would get us back to where we want to be as physicians and nurses. So I think the tools are there now, but the medical community is kind of a sclerotic, ossified one that doesn't like to change, isn't willing to embrace this technology in a way that to go after it rather than to keep questioning its value and whatnot. But I think it will be, we're already seeing many health systems that are starting to shift. That'll be the first phase of where we can start to have the keyboard need reduced. We're already seeing in some health systems, 2-3 hours per day reduction of that data clerk work. But where it can go is, of course, taking all the notes of a patient or all their records, not just the primary provider, but others, and synthesizing all those notes. We've seen how well that can be done through AI, much more concise, much more complete and accurate. We've seen many examples of that already. I don't know that how many times you have to prove that. And that doesn't really come under a regulatory purview. So those are some early wins. I think it will help many more. I mean, this is early in the medical AI integration, but I don't think we think enough about patients or that we're too conservative about trying to implement what are these tools that have a really tremendous impact for the things that we don't do well, which is processing lots of information on any given patient. The more complex the patient, the more this helps. And also the willingness to, let go and embrace AI rather than fear it.
Well, that's fantastic. I like the concept of embracing AI rather than fearing it. If you were to envision what care delivery will look like in, let's say, 5 years, maybe 10 years, what do you think it would look like with the adoption of AI? And I'll open it up to all three of you.
Well, I'm going to leave, I have read your papers, so there's one that's talking about. So I think if I look at embracing AI, what I look at it is actually looking at improved productivity and reducing the cognitive burden. Productivity in terms of the number of patients that could be taken care of, improved patient experience, reduced pajama time. Again, I'm talking about generative AI, especially with ambient listening. But even if you look at other clinical decision support tools, the way we have been interacting with AI has been not very seamless today. I anticipate with all the advancements and having vendors like our electronic health records and others clinical systems truly being interoperable at some point, there will be no data silos. That leads to much more seamless operations, especially even between payers and providers. I call it the battle of bots when we talk about trying to reduce the denials on the provider side, and at the same time on the payer side, we're trying to actually look at how do we deny a claim. So I see that battle of the bots going away and more seamless data ecosystem that's going to support a lot more decision making. And AI is integral. I mean, having that interoperability and data ecosystem is actually going to enable AI to be more seamless in interactions between the patients, the providers, and more importantly, the payers as well.
Well, I mean, the problem we have is we've seen in other domains how AI can improve efficiency and productivity, and that can be used against the clinical community. Because in this country, we have overlords who really like efficiency because it makes more revenue. And unless we do something about that and say our charge is taking care of patients, and the business of medicine is already way out of control in this country. So because of that structure, where very few health systems are run by physicians, but rather people that are financially driven, and this whole term patient first, I mean, come on, help me. If it was patient first, we wouldn't have 15-minute appointments. We wouldn't have all the stuff that we have. So that term is abused. So if we rebel against that, that will help. Because if we just let AI do what it can do, then you'd be expected to read more scans and slides and see patients in less unit time and all that sort of thing. And that's not acceptable. But that's the default mode in this country, which is different than a lot of other countries. So that has to be addressed somehow, because that's the thing that I worry about, that we have some really powerful means of improving medicine, getting the gift of time for the patient-doctor relationship to be brought back to the way it used to be decades ago, when it was a very impressive bond between humans for the presence of the doctor and, actually face-to-face, eye-to-eye with patient, listening, not interrupting after 8 seconds, having that sense of trust and knowing that the physician had your back. It isn't that way now. And we could get back there, but not with the structure in this country. So unless we do that, the 10 years, the rosy picture that we could think about isn't going to be actualized. At least that's my thought.
Yeah, if I could add a couple comments specific to the inpatient setting. Years ago, I haven't heard this phrase in quite a while, but we used to refer to the shadow chart. The parts of the chart that years ago we would say, well, that's not part of the legal medical record. Originally it was the handoff tool and other parts of the chart. We still have, areas of the chart that are like that. We have secure chat messages. We have the areas of the chart that I think many clinicians would say, well, that's where my real work is done. So I have kind of this vision that hopefully with AI tools, that becomes the space in which we have our clinicians working. And we have data captured through other sources, through ambient technology and so forth, of the data that we need to have captured in the chart, but that we really have these tools, these care team, tools to really engage in coordination of care. That right now, or for a long time, has happened verbally, and now a lot of it's on secure chat messages. And there is a lot of very rich information there that is not part of what we typically talk about when we're talking about EHR data. And I think we really need to keep this laser vision focus on what is it that clinicians really are doing in the care that they deliver to build tools that support that work.
Thank you. All fantastic thoughts. Really appreciate the insights of the panel. We'd like to open it up to questions, and I know there are some burning questions that have been there online for part of the day, so I'm going to ask An to share some of the questions for this panel and then open it up to the room for questions as well.
Mm-hmm. So the first question is, wondering what future you see in a small rural hospital who already struggles financially. Is there any possibilities with regards to grant funding in AI, or will they all be left behind?
So I'm going to speak to it because this talks about the spectrum when it comes to actually AI adoption. This is not just related to the science and the implementation, but it's also related to the equity piece, which is a huge, I would call it as a challenge when it comes to adoption. For small rural hospitals or for public healthcare delivery systems, which does not have an academic medical center setting, and more importantly, does not have their population as part of the cohort on which AI is being trained on. Most of the time, these hospitals and the populations being served is kind of being left out. So it's important to have a collaborative setting to also look at the marginalized population when it comes to building AI. That's one. The second is the cost to implement AI for organizations that has a very small margin or actually serving mostly being a safety net is the cost to implement AI is very high. So how as a community and how with private equity and tech firms that Dr. Ferris had spoken about this morning, how are we going to bring down the cost? So that's the second piece. The third piece is grants, philanthropies, where actually there is a focus on looking at the rest of the spectrum where AI acceleration and implementation requires funding. That be a focus for these grant institutions. There are few that do support some of the funding requirements, but it's not widely popular. It's not widely being adopted. So that's my take. Just being in a public healthcare setting, I see it's a huge dichotomy.
I mean, it's part of the inequity potential of exacerbating, further marginalizing entities like rural hospitals, or actually making it better. And I think that here, the other side of this, there's seen many examples now of AI leaning in towards fixing or improving these gaps. I mean, the one in NHS for mental health was one really great example, but we're seeing ability to use technology in the hinterlands, not just a rural hospital, but in places in Africa and South America that don't have technology, whereby the AI is being used to acquire through a smartphone images anywhere in the body, except the brain, by untrained personnel, just the AI instructing, move the probe counterclockwise, clockwise, up or down, and then automatically capturing the image and then getting auto interpretation. So there are many ways where AI can be used to help in this connected world, and there's no reason that rural U.S. hospitals wouldn't be part of that, but it will take some deliberate efforts to do that. It's not going to happen by accident.
Okay, we can move on to the next question. Every system is precisely designed to achieve exactly what result it gets. I'm seeing a lot of detection of burnout and advice on handling it, but I see very little on fixing the system that is designed to create it. Thoughts?
Well, if you want to fix the system, it seems to me you have to get it right that, what are we doing here? We're here to take care of patients. We're not here to be data clerks. We're not here to be, generate RVUs. We're here to take care of patients. And we lost our way. Let's admit it. That's not the case anymore. And patients feel it.
Yeah.
And even when they wait 9 weeks to get their appointment or whatever, they finally get their appointment, and that, they're not even being listened to. And they have a short drift of minutes. So, yeah, everybody's burnout because it's a horrible system that fell apart. And until we get that primacy of that bond together, the patient-doctor relationship restored, we're never going to get this right. But that means decompressing the work of every physician, every nurse, whereby they have the time and they're truly, communicating, and their natural empathy and why they went into this profession is being expressed. But the way it is right now, it's not workable. It's just been a steady erosion over many decades with no will to restore it the way it was. Yeah.
Now we have a question for Dr. Rossetti. Thank you for your excellent presentation. If you're picking up on nursing behavior changes, it begs the question, why not just ask nurses? Why do we need AI for what can be communicated in a brief discussion?
So the work that we've done actually can predict deterioration 2 days in advance. These are very subtle changes in a patient over time that the nurse detects. And so some of that is that the nurse is increasing surveillance, which means they may be increasing their monitoring of the patient. They may be assessing some things more frequently or differently. They may be holding certain medications. They're still kind of perhaps testing out, is this patient okay? Or are they going to deteriorate? So those conversations that you're asking about do happen, but we've actually been able to predict deterioration, we think, even earlier than perhaps some of those conversations, which is why we believe we observed the results that we did. Now, I'll mention that when we did much of our early work looking at these patterns in the ICU, when we see those nursing documentation patterns in the ICU, patients did better. We know in the ICU, the clinicians are all co-located. A nurse can talk with a physician right there who's sitting 5 feet away. And those conversations most likely happen more frequently. In the acute care setting, the patients, when these same patterns were observed, did worse. Those patients were more likely to have cardiac arrest and go on to die. So in that acute care setting, you have physicians who are not physically present on the unit. They're seeing patients on other floors in the hospital. Physicians have a very long list of patients, and they have a very long list of patients that they need to see right away. And so it all comes down to prioritization. And the work that we've done actually takes that nursing concern and turns it into an objective measure to know then when to escalate that care. So it assists these conversations and the shared team situational awareness in a way that gives a better sense of at what point, is this risk.
Thank you. I think we have a question in the back.
Great. So this panel has made me think about a historical situation where actually the law might be a way to speed the adoption of AI technology. So famously, Judge Learned Hand of the First Circuit created the legal principles by which commercial entities must adopt technology. And it's called the hand test for technology adoption. It's actually an algebraic formula, and that is that the cost of the adoption must be lower than the benefit accrued to what happens with adoption. This was actually, the test case was actually the adoption of a radio by tugboat drivers on the Hudson River. And there was a tugboat company that systematically didn't buy radios for their tugboats. And Judge Learned Hand said they were liable for losing there was a storm, and all the tugboats that didn't have radios sank, and the tugboats that did have radios didn't sink. It occurred to me that the hand test applied to AI, it works, the algebra works. And so when an investigator publishes a paper that says, we got more diagnoses right because of AI, from the moment that paper is published, or something like it, the onus will be, there will be a growing legal imperative to adopt AI because of the risk to the benefits to life that will accrue from having clinical decision support that is proven effective. I just wondered, Dr. Topol, if you would comment on whether or not you see that as a...
Yeah, I mean, you're bringing up an interesting concept, but I think you're fast forwarding and way beyond where we are today. So let me just say, firstly, that almost all the data that we have published is not in real patient data. It's with actors and it's simulations and it's retrospective. In October in JAMA, they reviewed 500 papers and less than 5% had real patient data. The real world of medicine is messy and you have to prove it in the real world of medicine and it hasn't been done. So we're missing compelling evidence. Number two, there have been 5 studies now, 2 in radiology and 3 in clinical medicine, whereby the AI outperformed the doctor with the AI. That's a little disturbing. It wasn't supposed to work that way. Now, of the studies, the possibilities are that these are contrived experiments, okay? It could be that the AI, there's automation bias, neglect. It could be that the doctors just don't know how to use the AI. They don't know how to use the prompts and whatnot to get to the diagnoses, whatnot. So we're at an early time. Now, finally, if we ever get to the point where you're at with the tugboat and the radios for medicine, the problem is that doctors don't like to be told to do anything, It's like vaccine mandates for the cuckoo people or the mask mandates. They don't like that stuff. So doctors won't like that if it's a law that they have to use the AI. So I don't know that even if we had the data where we're so far away from it, that's part of the problem. Doctors like to rule the roost. They don't want to let go to patients. They don't want to let go to AI. So I don't know that a law is going to help here, but it's an interesting idea that you're bringing up.
Yeah. Dr. Topol, I'm going to actually ask a follow-up if you don't mind. So talking about the workforce that comes into medical profession, doctors don't like it today, but do you see that the future of medical education would change where AI becomes part of the education. And so the Gen Alphas of this century are more equipped with AI to start with?
Yeah, absolutely. I mean, one of the interesting things here is that, we went through the whole era of genomics, and we never got our medical community grounded. The medical schools, really, 150 of them never changed their curriculum.
Yeah.
And now we're seeing the same replay with AI.
Yeah.
Now, what's interesting is, having done the NHS review, they have a whole wing of the NHS called Health Education England, and they did everything they could to train every clinician, doctors, nurses, pharmacists about genomics. Now they're doing that with AI.
Yeah.
And they want to be a world leader in AI. Where is our education? We don't even have one medical school that has AI in the regular curriculum. We have an elective, so we are way behind. And that, again, it's that willingness to change. It takes years to change a medical school curriculum, and that shouldn't be the case.
Right.
This is happening quickly. And patients, using ChatGPT and all the other subsequent iterations, are way ahead of physicians in learning, prompts and how to interact and enjoying it. I mean, a lot of them actually have fun with it, where the physicians are, they're using it, but they're much less, I think there's not any formal education. There's a couple of books that are pretty good that people haven't read largely that would help physicians, but that's not a formal education. I think it should be, something that we really work on. It's a great point.
Go ahead.
Great, thank you. I've read some of the similar studies where AI beats out the clinician plus AI and was similarly very shocked and concerned, but it also brings up a point that it keeps coming up throughout the day today, which is we as physicians oftentimes are at odds between sort of the guilds that we were brought up in and the doctrine and the way that we normally teach, the way we normally test and so forth, and what we now are looking at in the future. And it's going to be many of us as clinical leaders that are going to be trying to spearhead that movement forward. So how do we, both as leaders and as trying to affect change management, help that be something that is moving forward rather than sort of stuck in our own ways or in front of our own ways?
How do we affect change?
Yeah, essentially.
Yeah, that's a tough one. That's a really tough one. I guess the first thing is, if we have the realization that there's only one rescue mode here, and it's to lean on technology, because I don't see any. If you know of another one, anybody here, please let me know, because I'm not aware of another way we can get out of the situation we're in right now, which is relatively dire, because we're talking about, people's health and life and death and everything else. So that hopefully would be something that, we wake up to, that there's only one way out of this, and we should be going after it. And we're not right now. So if you start to see what the destination is, which is something that's got to be unidirectional, how could it get worse? Well, it could get worse. I mentioned one route, it could get worse. But for the most part, we're talking about things that everything that we do, we have help, which we don't today. And that help is probably, we're not even, whatever models we have today, whatever the latest benchmarks, they're going to get much better in the months and years ahead. We should acknowledge that. And so the concerns about confabulations and errors and, that sort of thing, it will never go away completely, but it just keep getting better. So we should be moving in that direction. And I don't know, the one thing I've learned over the years is changing this community is really difficult. It's really slow. And unless there's some new magical mega reimbursement, like, robotic surgery or something, where something crazy like, there's no way you get people to change. Is there a link to reimbursement that would do it? I don't know. It's very tricky to get change affected. It takes much longer than it should.
Yeah. Okay.
Who do you want?
I think I saw this gentleman raise his hand next.
I used ChatGPT to tell me between 1920 and 1938 what disruptive technologies occurred. So it gave me television, the jet engine, penicillin, synthetic plastics, radar, electric computers, automobile mass production advances, nuclear fission, broadcast radio, and helicopters. I don't know about helicopters. That seemed like, whatever. One of the, when you said, Eric, a second ago about, how difficult it is for us to change, and you mentioned reimbursement and the cost of procedures and tools, et cetera. I'm wondering if part of the problem is us in the difficulty in moving. I agree with you wholeheartedly about the challenge of teaching undergraduate professionals about something that in 10 years will be entirely different.
Yeah.
And we do have a community. We have a community of practitioners today who are learning and working together on the job. And I think that there's an opportunity, perhaps I would love to hear what you think, about bringing these AI tools to revolutionize the way in which they are learning in practice and revolutionize the way that their leaders are working with them to, whether it's efficiency or productivity or feeling better about working together in an institution, how we solve those problems with these technologies as well.
Yeah, I'm totally with you. I think Ethan Malik has a book called Co-Intelligence. He's a Wharton professor, so he's not in the medical field, but he writes about just spending 10 hours of your time on this, and you'll start to see the light, and you'll never go back. I think it's true. But yeah, this is one of our greatest challenges. It is on us. You nailed it. We're the biggest core problem. It's the overlords too. They don't help at all. But we're the ones that have to, push this and, take charge of it. And I don't know what you think, Diffie.
No, I think we are the problem. I
Yeah.
think, when you talk about the system, right, it's the system that we all create, irrespective of whether you're part of the government or a health system or a research institution, right? It's still the changes, there's inertia to change is hard. And I hope, that younger workforce, the future generation is actually changing the way they have been taught, so that not just talking about AI, just the infusion of all the technologies at their hand today, that becomes part of their life. And I see that big difference between me growing up 20 years ago to now. The whole notion of social media is new. And these kids are growing up with so much of infusion of technology, and hoping that some of this time spent on technology is used also in the education front. So we are preparing a better workforce for tomorrow. And change in medical education, like anything else, is hard.
And they're interdependent.
Yeah, they are interdependent.
All right. If I could add a comment to this, I think we need to reflect on too, saying, our clinicians might be resisting adoption, keeping in mind we're talking about highly burdened clinicians right now. They don't have time in any given day to devote to figuring out some of this technology and looking into it deeply. And so I think we really need to take an honest, look at what we expect of them when we then expect them to adopt it.
If I could just say, but we give clinicians 20 some hours to learn Epic. Why can't we put some of that time for this?
100%.
Yeah.
We need to provide that time to them,
Okay.
is what I'm saying. With that, we need to recognize that some of the innovations will fail. They won't fit. It won't be the right use case. And we have to make it easy for clinicians to give feedback about that. Not, them finding time outside of their, shift where they remember to get back to us. But we have to maybe bake it into the tools so that we're getting that real-time learning, because that's notoriously been a challenge, I think, in implementing some tools for clinicians.
Thank you. I know we are getting close to time. Do we have time for another question? All right, one more.
I have a quick one. In your interactions with clinicians, what's been a moment that you encountered some misconception about AI or technology that made you think, oh my gosh, we have so much education to do and this is a bigger problem? Like what kind of misconception did someone have?
A lot. And it starts with just understanding what is AI and what is not, right? I like Dr. Johat's the Venn diagram you had this morning. I think that by itself is a huge learning gap of what is truly AI. I call it a spectrum. Things that some of the clinical workforce calls AI is actually rule-based automation. And it can be done just based on rules. And the fancy word AI is the hype now. So it's really things, very basic foundations when it comes to what is AI and what is not, is, I would say, right, that's like an awareness learning, literacy 101. And again, I don't want to generalize that. I'm talking about, certain workforce. I don't want to say everyone is at that level. But there are different levels of learning, and we've got to start with literacy 101.
That's good.
Anything to add? All right. Well, let's thank our panel for painting a picture of the future.
So in this finely tuned meeting, we're ahead of time and under budget, right? When is sunset exactly tonight? 4:42, okay. Believe me, I'll give you extra time between now and sunset. But I've listened intently today, especially as probably the oldest person in the room and a true digital Luddite. I've been really intrigued by the conversation. And in terms of summative comments, one I have is AI is just another tool, right? I mean, civilization has been this process of learning how to use tools, and we're struggling a bit learning how to use this one. Related to that, though, medicine has always struggled a bit with tools. So it was not that long ago that doctors refused to let nurses measure blood pressures. I think that says it in a nutshell about how medicine can be reactionary, to use Jackie's phrase. We can act like a guild, and when a new tool comes along, we want to somehow protect it for use by the guild instead of democratizing it. And we just need to come to terms with that. That's why one of the most encouraging things about the collaborative on well-being is we have so many of the professional associations at the table. I mean, those are our guilds. And if our guilds realize that there is a greater good, as Eric was alluding to, we will get there. We will turn our guilds in the right direction. The other thing I learned over the years, especially as a health system CEO, is that healthcare and health systems, Don Berwick used the phrase, they're the last cottage industry. Tom Gilmore from the Wharton School referred to them as the ultimate loosely coupled organizations. And whether you view us as cottage industries, highly fragmented, or loosely coupled organizations, the bottom line is change is very hard within a loosely coupled organization. I learned that the hard way as a health system CEO. And today, the people that you report to, your health system CEO or whomever, he or she is really struggling to have enough bandwidth to just have a general sense of what's going on in the organization. It's very hard for them to carve out the time to say, we need to move in a new direction here, or we need to adopt this approach. And this is where I get to my plea for you. I think that to effectively change things in health systems, it requires the experts below the CEOs. It's not going to happen from the governing body looking at financials once a quarter. It's very hard for that CEO with their overextended bandwidth to lead change. It takes the experts in different areas to come together. And as I've listened to discussions today, you know, the people who are interested in wellness, the people who are interested in informatics and technology, and the people who are interested in the bottom line, and the people who are interested in clinical operations need to join forces on this. I would argue that the rapidity with which your health systems will intelligently adopt the use of AI really depends on the relationship and collaboration developed between those people heading those dimensions of things: well-being, clinical operations, finance, and IT. And so I would say what I would leave here, if I was still the CEO, I'd go back home and I would beg those 4 individuals to start working the problem. I don't know enough about it. I don't have the bandwidth to deal with it. But together, those 4 individuals, if they realize the common interests that they have, that each of their boats will rise, if we intelligently adopt the use of AI as rapidly as possible in our system, our finances will look better, our clinical workforce will be happier, our patients will be safer. All boats will rise, but it's going to take that kind of collaboration. Don't wait for the CEO or the board to mandate it. It probably won't happen. In most cases, they don't even know how good it could be if it does happen. But you have the ability to do that. So again, I think this is part of the wisdom of the collaborative, is we have people here from the guilds. We have people here who focus on the well-being side, people who focus on the IT side. There may even be 1 or 2 of you who care about the finances of the health system. In my experience, you know, if you have a happy workforce, safe patients getting good outcomes, your finances will be great. You don't even have to worry about it. This has been a great discussion. And now we're all going to go watch the sunset. I understand they're going to be giving blankets and fleece to keep people warm as the sun goes down. So thank you all again for taking time out today to join the group. Oh my goodness, it's Doctors Out.
I've been with you guys
here you
the
go.
Entire meeting. With the exception of about an hour for another, I've been with you all the way. It's just phenomenal meeting. And, you know, I'm not going to repeat everything we said. I'll just point out the following. Darryl, while you may be right, I think the system is much bigger than the individual health delivery system. It's the entire country. And until all these things are aligned in terms of mission, incentive, it's going to be a long time. And my other concern is that, yes, there's tremendous interest in the private sector entrepreneurism. They really have to come together in some way and do it in a coordinated fashion. I'm not as convinced, you know, right now, all the technologies are going to do exactly what they're meant to do, except they're doing it in different piecemeals. So there's a lot of other issues that needs to be addressed. Eric Topo is absolutely right. And, you know, we've got a system that's totally broken. And I think I would say that AI could help us fix it if only there was a more coordinated and approach that engages clinicians and others in a level whereby, you know, the payment incentive, everything else is aligned as well. But thank you. Have a great sunset.